And we're streaming live now on YouTube. Welcome to the Joint Standing Committee on Health Coverage Insurance and Financial Services. It's good to be back with you all the way, having been on my phone just for a couple of days dealing with some other things. We do have 4 public hearings scheduled for this morning. We do plan to take them in the order of their numerical publishing. So we will work our way through the list in that regard. I will be running a 3-minute clock today in order to try and get us through all of the hearings that we have in a timely manner so that our caucuses can meet over lunch to prepare for our work sessions this afternoon. And so without further ado, I will start with committee introductions, starting with Representative Quint.
Hello, my name is Tracy Quint. I represent House District 144, which includes Amity, Bancroft, Benedicta, Cary, Glenwood, Haynesville, Hodgdon, Holton, Macwahock, Molunkus, Orient, Reed, Silver Ridge Township, South of Rustic, and Weston. Thank you.
Thank you, Representative Quint. Representative Matheson.
Good morning. My name is Christy Matheson, and I represent District 1 Kittery, not quite as many towns there.
Representative Evans, who also has a long list.
Good morning. My name is Richard Evans. I represent House District 120, which includes the towns of Atkinson, Brownville, Dover, Foxcroft, Medford, Milo, Orneville Township, and Lakeview Plantation.
Representative Blyer.
Thank you, Madam Chair. Good morning, everyone. My name is Mark Blyer. I represent District 22, which is Leamington and part of Buxton, Standish, and Limerick.
Representative Malrano.
Good morning. My name is Gina Malrano. I represent House District 62, which is part of Auburn.
Thank you. Representative Arford, we'll get you next.
Yes. Thank you very much, Madam Chair. My name is Representative Poppy Arford, and I represent District 49, the western part of Brunswick.
Thanks. And Representative Morris.
Good morning. I'm Representative Joshua Morris. I represent the towns of Turner, Leeds, and Livermore.
Senator Brenner.
Thank you, Madam Chair. Good morning. I'm Stacy Brenner. I represent Senate District 30, which is most of Scarborough, some of Buxton, and all of Gorham. Thank you.
And Representative Tepler.
Good morning. My name is Denise Tepler. I represent House District number 54, which is all of the town of Topsham, and serve as House co-chair of the committee.
And I'm Senator Heather Sanborn. I represent District 28, which is half of Portland and half of Westbrook. We are ably assisted by our clerk, Christian Ritchie, and our analyst, Colleen McCarthy-Reed today. And like I said, we will be using a 3-minute timer. You're certainly welcome to keep your testimony even more brief than that if you would like. So at this time, we'll open a hearing on LD 1003, which is an act to improve outcomes for persons with limb loss. And it is presented by Colleen Madigan of Waterville. Representative Madigan, we will pull you in to join us now. Good morning, Representative Madigan. Go ahead.
Good morning, Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. I am Representative Colleen Madigan, and I represent part of Oakland and part of Waterville. I'm here today to introduce LD 1003, an act to improve outcomes for persons with limb loss. Like many of you, I find being in the legislature sometimes leads to meeting people you might not normally meet. Sometimes they share a problem or concern with you and let you know what they think needs to change. This bill comes out of one such meeting. Almost 2 years ago, I had the opportunity to meet a remarkable young woman. I was speaking to social work students about serving in the legislature as a social worker. You will get the opportunity to meet her today, but first let me tell you what she presented to me. Jordan Simpson is a college student and a person living with limb loss. We were discussing how legislators put in bills and how the process of passing a bill into law works. I shared that oftentimes the legislature puts in a bill because the person brings a problem to them and the bill proposes a solution. Jordan brought up a problem she knew only too well, and she educated me. Jordan shared that insurance companies do not consider the recreational needs of a person when authorizing the type of prosthesis they will reimburse for. I was not aware of this issue. Like most people, I have seen news stories of the amazing advances in prosthetics. I didn't know these were not widely available to those living with limb loss. In talking with Jordan, I learned about kids not being able to participate in sports with their peers, not being able to play tag as well as their peers. I thought back to being a child myself, playing hide and seek, tag, running. Play is such an important part of child development. Children learn through play. They learn not just the skills of putting one foot in front of the other, they learn how to interact with others through playing with their peers. This includes sports. Think of your own town. Around the corner from my house here in Waterville are the soccer fields, where every Saturday morning kids and their families gather for hours of youth soccer games. I thought a lot about those soccer fields as I was writing this. I also thought about the news stories of the amazing things Travis Mills can do. And I thought about the athletes in the Paralympics. If I had a child with limb loss, I would be shocked that my child would not be able to get a prosthetic that would allow him or her to fully reach their potential. At its heart, this bill is very simple. Recreational needs are completely valid. Recreational needs are not just about having fun. We all have recreational needs. They are human needs. They are crucial to our development and health as children and for our continued health as adults. Do you remember what it was like to run so fast as a child? I do. I remember feeling so proud I could run faster than the boys on my block. I used to love to run races with them. I used to love to play hide and seek. I loved to play softball as a child and as an adult. All these experiences play a role in our development and in our health throughout our life. People with limb loss should have the best possible chance to have these experiences. This is all this bill does. It requires insurance companies to meet a person's recreational needs as well as their medical needs when providing a prosthesis. It's that simple. I'm aware that this bill is a mandate on the insurance companies and of the process it must go through before it can finally be adopted. Thank you very much, and I look forward to working with you on this bill, and I'm happy to answer any questions.
Thank you, Representative Madigan. Are there questions for the sponsor? All right, seeing none, we thank you for bringing the bill to us. And next I'll call on Jordan Simpson. Good morning, Ms. Simpson. Welcome to our committee, and please go ahead.
Yeah, Senator Sanborn, Representative Tepler, and honorable members of the Health Coverage, Insurance, and Financial Services Committee. I'm Jordan Simpson, a senior at the University of New England, and I am here to support LD 1003. I was born with a multi-level limb difference, and I wear a prosthetic leg. Like any kid growing up, I wanted to move, to play sports, and to run around with my friends. But every day, my prosthetic just wasn't working. I would go to kick a ball, and my leg would sail across the field, but the ball would go nowhere. Just very awkward in elementary school. With its fixed ankle, I felt like I was running on a brick. I was told by insurance companies for most of my childhood it wasn't medically necessary for me to be able to run and access a running leg, as it is outside of activities of daily living, the standard used for coverage. The first time I was able to run more comfortably, I was 13 years old. And even then, I had to swap my feet onto one socket, as insurance would only cover part of the blade, which created many alignment issues as I stripped countless screws. I pulled my hamstring a year later while skiing, and even after physical therapy, I still shied away from making alterations to my leg out of the fear it would affect my walking gait. Heel height adjustable feet are also considered recreational, so I couldn't wear heels to prom. And forget about wearing any type of well-treaded snow boot that has a heel, because they just don't work. Even just a quarter of an inch is out of reach. I am here today to tell you that healthcare for disabled people needs to allow for recreation, potential, and joy. Circumstance, disability, whether born or developed, should not limit one's full participation in life. Life is more than bathing, dressing, and eating as ADLs prescribe. Recreational devices are essential long-term cost-saving measures to ensure greater health and well-being for people who live a life with limb differences. We know that recreational activity provides tremendous benefit in all areas of health and well-being, not just your physical health, including stress relief, improved self-esteem, and increased mental and emotional well-being. One of the leading risk factors for chronic health conditions is a lack of physical activity, and individuals with limb loss are at a higher risk of chronic diseases as they experience more difficulties in being physically active. Data from the CDC estimates that heart disease in conjunction with strokes cost our healthcare system $199 billion each year. $131 billion is lost in decreased job productivity, and diabetes-related costs reach about $237 billion each year. The Amputee Coalition reports that for every dollar spent on rehabilitation, there is a savings of more than $11 in disability benefits. This could increase with recreational device access. Studies show that misalignment that occurs in prosthesis leads to costly health issues such as back pain, arthritis, and many more. The same can be said for using a standard prosthetic for more intense recreational activity. Broadening insurance coverage to include recreational needs is essential. Recreation is not a luxury, it is a basic need. People with limb differences need to be able to move freely in their worlds and be active in a safe and healthy manner. Their lives, their health, well-being, quality of life, and opportunities depend upon it. Thank you, and I can take any questions, and I have a lot of resources in my written brief if there are none for now.
Thank you so much, Ms. Simpson, for your testimony and for being with us today. Are there questions for Ms. Simpson? All right. Thanks for presenting this issue for us.
Thank you.
And next, I will ask if there's anyone else in our Zoom meeting who wishes to testify in favor of the bill. If you'd please use the raise hands function now. All right, seeing none, we'll switch to those opposed to the bill. And I'll call first from Bruce Garrity. Good morning, Mr. Garrity. Go ahead.
Morning. Thank you. Senator Sanborn, Representative Tepler, members of the committee. My name is Bruce Garrity. I'm here on behalf of the Maine Automobile Dealers Association, which has a multiple employer welfare arrangement, also called a MEWA. Just by way of very quick comment, MEWAs are self-insured plans. The participants, in this case, new car dealers, pay their own claims, collect their own premiums, are regulated independently by the Bureau of Insurance, and they have no profit motive. Their goal is to provide comprehensive health care at the lowest possible cost. We do have a number of concerns with this legislation. This is not to say that we, like anyone else, don't have empathy for individuals who have these kinds of challenges. But as a practical matter, we don't think this is workable as part of a healthcare plan. There are several reasons for this. First, many times this would require a C leg or a computerized leg. Those are between 5, 6, sometimes 7 times as expensive as a more standardized prosthetic limb. Second, they last significantly shorter periods of time. While there's no limit on the costs associated with this under the law, there are limits on how often a limb, a prosthetic has to be replaced. And I think you could run into situations where individuals have their limbs start to fail before the period of time when a new limb might be available. A third concern we have is, what is a recreational activity and what does it involve? And how how sophisticated does the limb have to be? There are limitations to these limbs. Is the idea that one should be able to fully rock climb or play basketball or any other strenuous activity that requires a lot of specified different skills. That's not to say we don't want individuals to be able to engage in these activities, but the costs associated with some of these prosthetics would be exceptionally high, and that's something we think you should consider. Another factor might be, is there a need for a specified limb for a specified purpose recreationally, apart from the need of the needs associated with a regular prosthetic? In other words, does a person need more than one? And if so, thank you, Senator, what are the costs associated with providing more than one, and should more than one be provided, and is more than one to be provided under the law? I see my time is up. I appreciate this opportunity to have made these comments. And Senator, I'd be happy to try and answer any questions the committee might have.
Thank you, Mr. Garrity. Are there questions for Mr. Garrity? I don't see any, so we thank you for your testimony. And next we'll call on Christine Ossenfort. Good morning, Ms. Ossenfort. Go ahead.
Good morning, Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. My name is Christine Ossenfort, and I am the Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, Maine. I appear before you this morning, it's a long day already, in opposition to LD 1003. Mandated benefits are always well-intended, and they are difficult to oppose, but they do increase costs. A mandated benefit study presented to the committee last year indicated that mandates represent about 9.3% of premium for individual plans, nearly 10.7% of premium for small group plans, and that defines small group as less than 20, and about 10.6% of premium for groups with more than 20 members. So we would urge the committee that if you are interested in pursuing this legislation, that you do send it to the Bureau of Insurance for a mandate review study to better understand the costs that might be associated with the proposal. And finally, we would note, as the committee is aware, this would not apply to the Medicaid program, the Medicare program, or self-funded plan. So with that, I'd be happy to answer any questions you may have. And I will, of course, be present at your work session as well.
Thank you, Ms. Ossenfort. Are there questions for Ms. Ossenfort? I have a question, and perhaps you can bring it back for the work session. Mr. Garrity noted a number of sort of unanswered questions about what would have to be covered and how often limbs would have to be replaced and so forth. So I'm hoping that you could provide us with some information about how Anthem handles those questions under the current law, which does mandate coverage for medically necessary prosthetics.
Right, so I'd certainly be happy to take that back.
Okay, thank you. Representative Quinn.
Thank you. Thank you, Madam Chair. This actually goes along with your question as well. You can have for the work session what the basic replacement is for that prosthetic. Is there something that overall it's a baseline of what's given to people that are dealing with this, or if different things are taken into account from physicians saying that they need to be more mobile for certain things that they're doing, whether or not it has to do with like a genetic issue where they'll have a problem with this, and maybe the muscles will degenerate as well. So if just something along the lines of a baseline so we see what we're looking at, that would be appreciated by me. Thank you.
Yeah. Okay, are there any additional questions? All right, seeing none, we thank you for your testimony and for your assistance in preparing us for the work session. And next we'll hear from Catherine Pelletreau. Good morning, Ms. Pelletreau, go ahead.
Good morning, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I speak today for the Maine Association of Health Plans in opposition to this bill. I think you've heard pretty much everything that I had in my testimony. The one piece that I would add, these are always tough because Ms. Simpson's situation is compelling and her quality of life might be improved by a specialized prosthetic. But it's absolutely accurate that carriers, both public and private, typically don't cover those specialized prosthetics. They can be very, very costly and are not seen as medically necessary. That said, I will take the liberty, with the permission of the committee, of taking the 2 questions that have been raised already back to our membership to bring you some more information for the work session. Thank you.
Yeah, that would be really helpful, Ms. Paltrow. And thank you for sort of intuiting what my request was going to be, which was to expand the data request beyond just Anthem. So thanks for helping us facilitate that. Representative Matheson.
Thanks so much. Thank you, Ms. Paltrow. Could we add on that data, just do you have information on how many people actually in Maine require this service? That would be great. Thank you.
Just to clarify, you mean any prosthetic at all?
Mm-hmm. Just numbers.
Yep.
Thank you.
I will try. Yeah, I'll try at least for private health insurance.
Right. I think commercially insured regulated plans is what the scope of the population is that we're talking about. Representative Arford.
Yes, thank you very much, Madam Chair, and thank you very much, Ms. Paltrow, for being with us today. I know just a little bit about this. I think it's such a worthy bill. And so my question is this. Are you aware of, I'm sure that this is not a new issue for the insurers, of people wanting more advanced prosthetics to allow them to improve their quality of life? I'm quite sure there's foundations, there's other resources for people who are seeking these services. And I'm wondering if the insurers provide any information to a member when they deny such a request from, I'm sure it would come from a doctor requesting a service like this for their patient. And if you deny it, do you provide any information to the patient as to where they might be able to go to have their needs met? And that's one question. The other question is this something that is an ongoing conversation within the insurance industry? Is this something you're already discussing? I mean, it's definitely a very worthy subject. And I'm just wondering if there's a conversation going on already about it and what that might be. Thank you.
Excellent questions. I'll take them back.
Thank you, Ms. Paltrow. Are there any additional questions for Ms. Paltrow? Representative Melrano, go ahead.
Thank you, Madam Chair. Yes, one more question, and it may have been asked, but how do you define medically necessary? Like, is that simply the ability to do the activities of daily living, like Ms. Simpson referenced, and how do you define activities of daily living? That would be my question. Thank you.
Mm-hmm. You'll see in my written testimony, the definition, there actually is a pretty clear definition of what the activities of daily living are. It's being able to feed, cleanse, dress oneself, sit, stand, walk. So it does not, I don't believe it typically covers things like running or climbing.
Or exercise, really.
Walking.
Correct. Yeah, okay.
I hear you.
For walking to be exercise, it does somewhat have to be for a long period of time, but okay, that's helpful. Thank you so much.
Representative Tepler.
Thank you, Madam Chair. And I don't know if this question has already been asked either. I don't think it was, but do we have a sense, or can Ms. Paltrow provide us with a sense of what the average cost of one of those computer-aided prosthetic limbs is?
I did provide some cost information in my testimony for a lower leg limb, which was about, between $10,000 and $70,000, and can be higher than that depending on the level of specialization and sophistication.
Yeah, I'm not looking for Oscar Pistorius's leg, but I would like to have a sense of what would allow a teenager to run, to participate in activities that are normative for a teen in a gym class, for example.
Representative Tepler, Ms. Palatro's written testimony does include a link that provides some of that information.
Thank you. I
Yeah.
haven't had an opportunity to look at it yet. Thank you.
Yeah. And just one more piece of, if we could get clarification on whether walking upstairs is considered an activity of daily living, and also whether walking on uneven ground, which requires an articulating ankle, is considered medically necessary. That would be helpful. Thank you. Okay, great. So yeah, it sounds like it may be helpful if it's possible for you to prepare some sort of memo or written response for us. That would be really, really helpful prior to the work session. We can certainly make sure that the work session isn't scheduled too quickly to allow you a week or so to collect that information, if that would be feasible, Ms. Paltrow. Great. Okay, are there additional questions? All right, seeing none, I will ask if there's anyone else in the Zoom meeting who intended to testify orally in this hearing today. Please raise your hand. And seeing none, I'll close the hearing on LD 1003, and it will be scheduled for a work session a week or more from now, so that we give a chance for some written response to the questions we've asked this morning. And with that, I will turn the gavel over to my co-chair, Representative Tepler, for the next bill.
Thank you, Madam Chair, and also Senator Sanborn, who we're going to call on to present the next bill to us. Please go ahead.
Thank you, Representative Tepler and honorable colleagues of the committee. I am here to present LD 1115, an act to improve access to HIV prevention medications. When I was growing up, like most of you, HIV was spreading rapidly, and people who acquired HIV were very likely to develop AIDS and become very sick with a shortened life expectancy. Today, we're incredibly fortunate to have PrEP, pre-exposure prophylaxis, and PEP, which is post-exposure prophylaxis medications that are highly effective in preventing HIV either before or after one is exposed to the virus. Just like so many other drugs in this country, however, there are barriers that can get in the way of people accessing PrEP and PEP medication to prevent HIV. LD 1115 will work to break down some of these challenges that stand in the way of folks accessing these life-saving preventative drugs. This bill requires an insurance provider to cover at least one HIV prevention drug, and for at least one drug to be covered without needing a prior authorization. The bill also sets up a process in which, under certain conditions, pharmacists can dispense up to a 60-day supply of an HIV prevention drug without a prescription from a physician. Pharmacists would need to adhere to board-approved rules and protocols in doing so, and I'll just highlight that it also requires the pharmacist to assist that person in finding a primary care provider who can continue their care after the 60-day supply. We need to do everything we can to increase access to PrEP and PEP drugs in Maine. Passing this legislation will help us get there by requiring insurance coverage, speeding up the process of getting the medication, increasing access by enlisting the help of participating pharmacies. Thank you for your time. And I just have a couple of other points as I've learned a little bit more about this issue over the last few days. First, I will note that the U.S. Preventative Services Task Force has deemed PrEP medication, HIV preventative medication, to be part of its preventative services recommendations. So I think in that regard, because it is a level A preventative measure, it is already falls under the ACA's required coverage mandates for first dollar coverage. So I think we'll hear a little bit more about that from others who are going to testify behind me. But I think there is some question, and I don't know if it's an issue here in Maine, but it's an issue in some with some insurance companies, whether the blood testing that is required to be done, I think quarterly when you're taking this medication, is also considered to be a preventative covered service. So I encourage us to think about whether the bill may want to be brought or amended to clarify that the associated labs that are required in order to continue on the PrEP treatment be considered part of the preventative treatment protocol and therefore covered as a preventative service with zero copay. So that's just one little twist that we may want to further look at as we continue our consideration of this bill and try and make easier access to this incredible medication that prevents an infection from occurring and will keep people safe in Maine. So thanks so much for considering the bill, and I'd welcome any questions that you might have.
Questions from the committee for Senator Sanborn? Seeing none, thank you for your testimony, Senator. And I will now turn to proponents of the bill, since I don't believe there are any co-sponsors in the queue. And first up, I will call Ms. Alicia Melnick of Equality Maine. Please join us. Good morning.
Good morning. Senator Sanborn, Representative Tepler, members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Alicia Melnick, and I'm here on behalf of Equality Maine, the statewide LGBTQ civil rights organization. Equality Maine supports LD 1115, an act to improve access to HIV prevention medications, and we'd like to thank Senator Sanborn for her leadership on this bill. This bill, as you heard, is about expanding coverage and access to PrEP and PEP. So a little bit of background info on what they are would probably be helpful. As you've heard, PrEP is the shorthand way to say pre-exposure prophylaxis. It's a prevention strategy where HIV negative individuals take a single pill once per day. The medication works to prevent HIV from establishing infection inside the body. Similarly, PEP is the shorthand way to say post-exposure prophylaxis and is a 28-day regimen used in specific instances following high-risk exposure to prevent HIV infection. Truvada, the first PrEP drug, was approved by the FDA in 2012, and since then, studies have shown that PrEP can reduce the risk for HIV infection by up to 99% when taken consistently. In just the last 2 years, there have been several new significant developments. In October 2019, the FDA approved a second drug, Descovy for PrEP. Then in December 2019, the Trump administration announced a new program called Ready, Set, PrEP, with the goal of distributing enough free PrEP to cover an additional 200,000 people per year for the next 11 years. Finally, in October 2020, a generic version of PrEP came online. With scientific consensus that PrEP works to prevent new HIV infections and bipartisan leadership working to promote this medication, you may be wondering what's the problem. As is often the case, the answer is insurance coverage and access. The issue of insurance coverage may be the easier one to address. Due to the Affordable Care Act, regulations, and recent action by the U.S. Preventative Services Task Force, most private insurance plans must cover PrEP with no cost sharing starting in 2021. Our colleagues at GLAD articulate this in greater detail in their testimony, and we support their suggestion that this bill be amended to conform with the federal requirement of no cost sharing. The issue of access is more challenging and will require multiple strategies to get this critical medication to those who need it. The bill before you proposes one such strategy, allowing pharmacists to dispense small supplies over the counter. A few key points. First, pharmacists would not be required to participate, but if they choose to do so, they would be required to complete a training program approved by the Board of Pharmacy to ensure they have the knowledge and skills to be able to counsel Mainers on use of the medication. Second, because pharmacists would be limited to dispensing a short-term supply, an ongoing subscription for PrEP would still require contact with a primary care provider. We view this as a critical element because it would both address the immediate short-term medication needs and also ensure a patient's ongoing healthcare needs are being addressed. The HIV/AIDS epidemic has now been raging in the United States for more than 40 years. We've lost far too many people way too soon. I'll wrap up. Far too many new cases are still diagnosed. Because it's 99% effective at preventing new infections, this is the kind of game changer that can help end this crisis. The Trump and Biden administrations both have taken action on PrEP, and last year this legislature also took action. We urge you to take the next step by supporting this bill. Thank you so much, and I'm happy to answer any questions.
Thank you for your testimony, Ms. Melnick. Are there any questions from the committee for Ms. Melnick? Yes, Representative Quint, please go ahead.
Within this bill, I don't have all of the information about it, but if someone were to go to a pharmacist and get this, not go to a physician, can they then go to another pharmacist, get it without going to a physician, and so on? And then also, if this is something that's taken year round, do you have an average cost estimate of what this would be per person having to take this? Thank you. Oops. Sorry, I'm speaking about the actual PrEP as opposed to the PAP.
I don't have a cost estimate, but that is certainly something we can help try to gather information for the work session. And as far as the limitation, there is a limitation on a pharmacist dispensing a certain amount. As far as additional pharmacists, going from pharmacist to pharmacist, how that communication would happen. I will look into that as well. There may be people behind me in the testimony line that can answer that question for you.
Thank you, Ms. Melnick. Any other questions from the committee? Seeing none, we'll move to the next proponent of the bill, Mr. Lombardi of GBLTQ Legal Advocates. Welcome, Mr. Lombardi.
Representative Tepler, Senator Sanborn, and honorable members of the committee, good morning. My name is Anthony Lombardi, and I'm a legal fellow at GLBTQ, Legal Advocates and Defenders, New England's leading legal advocacy organization for LGBTQ rights. And I'm also a lobbyist associate of Mary Bonato, who lives in Portland. GLAD strongly supports LD 1115 because it expands access to a simple, safe, and effective medication, PrEP, that provides our best opportunity to end the HIV epidemic. The bill will allow the most vulnerable populations to obtain PrEP quickly, remove cost barriers to PrEP, and improve access to care. PrEP reduces the risk of acquiring HIV via sex by about 99%. However, it is underutilized generally in rural communities and due to racial disparities. A geographic survey found that 1 in 8 PrEP-eligible gay and bisexual men lived in a 30-minute drive desert, and a sizable minority lived in a 60-minute drive desert. Several of Maine's counties would fit these desert definitions. Further, of the nearly 38,000 new HIV diagnoses in the United States in 2018, approximately 58% were among Black and Latinx individuals, and Maine is no exception. The most recent available data shows that 30% and 41% of new HIV diagnoses in the state were among people of color in 2018 and 2019, respectively, despite representing only about 7% of the state's general population. LD 1115 is a simple and innovative bill to expand critical access and connect individuals in the healthcare system in Maine. LD 1115 also remedies cost and coverage barriers to PrEP. Requiring carriers to cover HIV prevention drugs without prior authorization or step therapy can remove a potential barrier to treatment for otherwise eligible individuals. And as previously mentioned, with that in mind, GLAD would like to bring the current federal framework to the committee's attention as the basis for a proposed amendment to LD 1115. Section 2713 of the Affordable Care Act incorporates evidence-based services that have a rating of A or B in the requirement that non-exempt private health plans provide coverage for a range of preventative services and prohibit cost sharing, such as co-payments, deductibles, or co-insurance on patients receiving these services. PrEP received a grade A recommendation in June 2019. As such, PrEP medications must be provided at a zero cost basis for plans covered by Section 2713 of the ACA, which includes most private plans and all plans in the ACA marketplace. GLAD would therefore, in keeping with federal guidelines, recommend amending Section 4317D2 of the bill to require that medications be offered at a no cost sharing basis rather than the lowest available cost sharing basis. GLAD would also refer the committee to the community position statement submitted alongside this testimony, which over 30 organizations and advocates urged the committee to pass LD 1115. Thank you for your consideration, and we hope that you'll unanimously vote on to pass. Happy to answer any questions.
Thank you, Mr. Lombardi, and thank you for staying within the time limit. Awesome. And I see a question from Representative Matheson. Please go ahead.
Thank you, Madam Chair. Thank you, Mr. Lombardi, for testifying and giving us so much good information. Can you just reiterate what part of the bill, you said it really quickly, so I was just looking at the text, where in that amendment that you're suggesting?
I believe it would be amending Section 4 of the bill, which would amend the revised statutes annotated 4317D. Basically, instead of saying the lowest cost tier, provided at no cost sharing basis.
Any other questions for Mr. Lombardi? Seeing none, thank you for your testimony. And now I will turn to Nicole Clegg.
That's always so stressful.
I've taken to calling it the wormhole.
Good morning, Senator Sanborn, Representative Tepler, and members of the Joint Standing Committee on Health Coverage, Insurance, and Financial Services. My name is Nicole Clegg, and I serve as the Senior Vice President of Public Affairs at Planned Parenthood of Northern New England. And I'm pleased to submit testimony in support of LD 1115. Planned Parenthood of Northern New England provides comprehensive reproductive and sexual health care to more than 14,000 people in Maine at 4 health centers located in Biddeford, Portland, Sanford, and Topsom. People turn to us for affordable, high-quality care, including wellness exams, birth control, disease testing and treatment, cancer screenings, abortion care, as well as a variety of other primary care services. We see everyone who comes to see us, regardless of ability to pay, and in a typical year, we provide more than $4 million in free and discounted care to our communities in Maine. In many communities across the country and in Maine, Planned Parenthood health centers are an essential source of comprehensive HIV prevention and education, including counseling and evidence-based innovative prevention options for individuals at high risk. We fully support this legislation as it would help ensure people have access to the medications they need to keep themselves and others healthy. With the availability of highly effective HIV prevention tools, PrEP and PEP, we can look to a future with renewed hope of ending the HIV epidemic. But that is only a reality if the medications are affordable and accessible to those who need them. We know that many people encounter barriers to this critical care because of lack of availability, insurance coverage, cost, and stigma, which is why policies like LD 1115 are so important. The legislation is straightforward and a proven approach to help mitigate barriers for people at the greatest risk, as the bill would provide coverage and expand the points of access for PrEP and PEP, helping to bring these treatments into the mainstream and reduce the stigma associated with STIs and HIV. A stigma that is further exacerbated by racism, anti-LGBTQ discrimination, and other structural barriers. Gay, bisexual, and other men who have sex with men, particularly those who are Black and Latino, are at greater risk of getting HIV, and Black women are at higher risk than other women. It's important that everyone, especially those communities most affected, have access to testing, PrEP and PEP, and other prevention tools. Stigma, misinformation, and fear all too often prevent people from accessing the medications they need to protect themselves and others. But the stigma is curable, and that's why it's so important for health promotion policies to incorporate HIV prevention into their overall strategy. Thanks for the opportunity to share our support, and we urge you to vote ought to pass on LD 1115.
Any questions for Ms. Clegg? Seeing none, thank you for your testimony. And we'll turn to the next proponent of the bill, Logan Mills.
Sorry about that. Here I am. Oh, thank you. Senator Sanborn, Representative Tepler, and honorable members of the Committee on Health Coverage, Insurance, and Financial Services. My name is Logan Mills. I'm a community organizer living in Portland, Maine, but today I will be testifying as a private citizen in strong support of LD 1115, an act to improve access to HIV prevention medications. For the last 4 years, I have been taking Truvada for PrEP. It is difficult to overstate how revolutionary this drug has been for myself and other members of the LGBTQ community. But I am not currently taking Truvada, and I will not be able to until I pay the $4,600 bill that I owe to the out-of-state specialty pharmacy that my insurer requires me to use. Truvada costs $1,800 per month. In the past, my health insurance company paid for all but $500 of the monthly cost, and then a copay assistance program through the drug manufacturer paid for the rest, leaving me with no charge for the medication. So what happened? Well, last year, my health insurance company decided that they would change the way that they pay for Tier 5 drugs such as Truvada and Retrovir, one of the primary drugs used to treat people who are HIV positive. They would no longer contribute a cent toward the monthly medication cost until I hit my $3,000 out-of-pocket deductible. At the time of the policy change, there was no available generic for Truvada. After draining $7,200 in copay assistance funds, which did not count toward my out-of-pocket deductible, I was left with a $3,000 charge to hit my deductible and then 500 monthly payments for the rest of the year. My insurer's failure to adequately inform impacted patients of this policy change meant that I didn't know anything was wrong until I was informed of a $4,600 bill in February of 2021. It is unfair and immoral that the cost of a drug that is so desperately needed by my community can be raised from $0 annually to a minimum of $3,000 per year, especially when there is no available generic. The LGBTQ community has always faced an uphill battle with access to healthcare, and health insurance companies today are carrying on that tradition with no consequences. LD 1115 would insulate my community from predatory policy changes like the one I experienced by requiring PrEP to be covered at the tier with the lowest cost sharing requirement on the carrier's formulary. It is also worth mentioning that my current situation would have been avoided if LD 1151, an act to lower out-of-pocket prescription medicine costs by requiring health insurers to offer plans with no deductibles, had been in place. My insurance carrier did everything in their power to keep me from hitting the annual out-of-pocket deductible that would have required them to start assisting me with the cost of this medication. Mainers deserve healthcare plans that provide consistent coverage of their medication cost. As a member of the vibrant Maine LGBTQ community, I am urging the committee to vote ought to pass on both LD 1115 and LD 1151. Thank you, and I would be happy to answer any questions.
Thank you, Logan Mills. And I will ask if any members of the committee have a question for you. Seeing none, thank you very much for taking time to give testimony today. We appreciate it when a private citizen takes time out of their day to speak to us.
Of course. I was wondering if I could perhaps respond to the question asked by Representative Tracy Quint quickly, just regarding patients going to multiple pharmacists to get PrEP. I would just ask her to consider what sort of patient might be in a position to not have regular access to a primary care provider and would need to go to multiple pharmacies to get short-term supplies. I think that speaks to a lack of medical infrastructure, not a lack of good behavior on the part of the patient. Thank you all so much.
Thank you, Mr. Mills. Do you have, oh yes, Ms. Quint, I'm sorry, Representative Quint has a follow-up.
No worries. Thank you. Okay. Yes, thank you for doing that. I will be doing on this as well. The question I have is you're talking about a deductible. Are you wanting to not have to pay your deductible before, like, receive the medication and not have to pay a deductible?
Yes, because that's what the policy currently is with my health insurance provider, and that's what their policy was in 2019. I did not have to hit my out-of-pocket deductible before they started providing that copay assistance. And the fact that they were able to make this change without any sort of consequences and raise that price effectively from $0 to $3,000 annually, I feel is predatory and immoral.
Okay. Yep. I'll check into that. I know whenever I go to get something, I do have to pay my deductible. So I want to make sure, you know, where that actually stands. So I'll check on that further. Thank you.
Absolutely. I also do think that there's an issue with the fact that copay assistance funds don't count toward that deductible, despite the fact that the insurance company themselves is not supplying that money. But that's probably a different bill.
All right, thank you very much. And I'm going to move on to another proponent of the bill, Mr. Morin of the Maine Medical Association. Mr. Morin, please join us.
Good morning, members of the committee, Chair Sanborn, Chair Tepler. I literally 20 seconds ago just finished testifying in another committee, but we're all doing that. So this virtual aspect is great. So I don't have to run from room to room and fall on my face and drop. So thank you for the opportunity to comment in support of LD 942. I'm not going to get into the efficacy of PrEP. It's a wonderful process and much needed for a segment of the patient population. The American Medical Association advocates for policies similar to the bill. Our legislative committee took a look at it. The only thing we would ask is offer an amendment on page 3 of the bill, line 21. We ask the duration be changed from 60 days to 30 days. And the goal here is, from what I hear from practicing physicians that are involved in this process, the current standard for follow-up appointments for further education and consult about PrEP, reviewing whether it's daily versus on-demand, testing, other lab work is usually 2 to 4 weeks after the first prescription. We think amending it from 60 days to 30 days would still offer the necessary access, cover the bill proponent's concerns, but also integrate that treatment and process with the promotion of a medical home model with the goal to meet the whole person's healthcare, both physical, mental health, all elements of the system, and an emphasis on consistent care transitions. I'd be happy to answer any questions, and we thank some of the proponents of the bill for approaching us on this, and we're glad to support it.
Thank you, Mr. Morin. Any questions from the committee for Mr. Morin? Seeing none, we appreciate your testimony. And I will move on to Ren Morrill of the Franny Peabody Center. Welcome.
There we are. Sorry about that.
Okay.
Madam Chair Sanborn, Madam Chair Tepler, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Ren Morrill, and I'm the Prevention Program Coordinator at Franny Peabody Center, Maine's oldest and largest community-based HIV/AIDS service organization. I'm here today in support of LD 1115, as it will get us one step closer to ending HIV/AIDS, an epidemic that has raged for nearly 40 years. PrEP was approved by the FDA in 2012 as a daily pill to prevent HIV infection and is widely recognized as the tool that can end the HIV epidemic. Yet, people still face barriers to accessing PEP and PrEP, whether it be cost, coverage, physical distance, or lacking a trusted provider. In my 4 years as the prevention program coordinator, I've learned that HIV prevention is often a matter of timing. People seek services after having a significant risk of HIV infection. When faced with barriers, complicated means of access, and stigma, many clients may not see a feasible way forward. It is in the crucible of this moment where the real prevention work occurs. This legislation offers a direct, smooth, and efficient pathway to care through a trusted pharmacy provider. As someone who answers the call and counsels people at very high risk, I can say with confidence, being able to link them directly to a pharmacist for PrEP or PEP will make the difference between someone becoming infected with HIV or remaining HIV negative. We've seen this strategy work with lowering the barriers to HIV testing by meeting clients where they are, whenever they need the service. This bill is an extension of this low barrier approach to prevention. It would not only allow patients rapid access to PrEP and PEP, but would ensure that they are seamlessly linked to other supportive services such as primary care. This bill puts patient needs first by supporting individuals' continued engagement in care, which contributes to positive health outcomes, sustained well-being, and a pathway to ending the epidemic. If the past year has shown us anything, it is the importance of low barrier services in tackling public health crises. I urge you to support LD 1115 as it expands access to critical HIV prevention tools. And I'm happy to answer any questions. Thank you all very much.
Thank you for your testimony. Are there any questions from the committee? Seeing none, we appreciate your appearance, and we'll call the next proponent, Whitney Parrish. Is Whitney Parrish available? Yes, I see Whitney there.
Good morning.
Good morning.
Good morning, Senator Sanborn, Representative Tepler, and distinguished members of the committee. My name is Whitney Parrish, and I'm the Advocacy and Communications Director of Health Equity Alliance. I'll tell you a little bit more about us as we move along. Health Equity Alliance has offices in Bangor, Belfast, Calais, Ellsworth, Machias, and Rockland, and we do statewide advocacy. HEAL strongly supports LD 1115 because we see every day how access to low to no barrier destigmatized services for our clients improve their lives and keep them safe from contracting preventable infectious diseases like HIV. We believe creating simpler access points for PrEP and PEP is key to a prevention effort that will move us closer to ending the HIV epidemic that has claimed too many lives, placed too many vulnerable people in financial and medical crisis, and is a direct example of how our healthcare system and government supports have ultimately failed both the LGBTQ+ community and people who use drugs intravenously. Health Equity Alliance carries on the work of our founding organization, the Downey's AIDS Network, which merged with its sister organization, Eastern Maine AIDS Network, in 2013. For over 30 years, we've provided HIV/AIDS care to countless individuals throughout Northern, Down East, and Mid-Coast Maine. We've also offered extensive education throughout the state and the region through our partnership with the New England AIDS Education and Training Center. At HEAL, if we've learned one thing through our service provision, advocacy, and education efforts, it's that stigma reduction is critical to accessing the appropriate care needed to keep people safer, healthier, and connected to their community. We hear time and again from our community that the presence and availability of PrEP is a significant stigma reducer, and its very existence breaks down walls of shame and barriers to safety, security, and wellness. In turn, that normalization creates opportunities for access to critical prevention tools and increases the use of those methods, reducing the stigma of PrEP and PEP access by making it safely available through participating pharmacists supports people, communities, and the vital public health infrastructure often cited as a barrier to appropriate care in rural areas like Maine. As a service provider working with people who inject drugs, we meet countless community members who have experience with the collateral consequences of limited and confusing public health infrastructure, arbitrarily challenging access to healthcare, generational patterns of poverty, and lack of access to a consistent healthcare provider for many vulnerable citizens who may be in need of direct, specific, and attentive care. These barriers are cited as primary reasons why underserved rural communities have higher prevalence of HIV. Easy access to PrEP and PEP for people who inject drugs gives rural and vulnerable Mainers another avenue to stay safer and healthier, and it gives them an opportunity to be connected to healthcare they need and deserve. Being able to guide our clients to this care and then work with them to ensure continued access to that care would be an actual game changer for our community. In the world of harm reduction, we know that simple, pragmatic, I'll wrap up, dignified solution to often complex challenges are the ones that resonate and work. We believe LD 1115 embodies this description and can help achieve this outcome. We urge the committee to vote ought to pass, and I'm happy to answer any questions you may have.
Thank you very much. And are there any questions from the committee? Seeing none, thanks a lot for your testimony.
Thank you.
And next we'll turn to another proponent of the bill, Katie Rutherford of the Franny Peabody Center.
Hi, everyone.
Welcome.
Thanks very much. Madam Chair Sanborn, Madam Chair Tepler, and members of the Health Coverage, Insurance, and Financial Services Committee, my name is Katie Rutherford, and I'm the Executive Director at Franny Peabody Center. Like my coworker, Ren, who you have also heard from, I'm one of the certified HIV testers at our agency. I remember a gentleman who came all the way down to Portland from a small remote island off the coast of Maine just to access a confidential HIV test because he was concerned about possible exposure and didn't know where else to turn. He was also worried about possible disclosure within his small community should his test come back positive. Even though PrEP had been approved by the FDA years prior, he had never heard of it. His test was negative. I gave him as much information as I could and sent him hours back up north, knowing he would likely be at risk again. Had this legislation been in place, I could have pointed him directly to a pharmacy that day and linked him to trusted prevention services that could have provided long-term protection from HIV infection. I also want to take a moment to remember Ryan White, who passed away from AIDS-related illness 31 years ago today. The legislation enacted in his name has expanded access to care for people living with HIV and AIDS through medication coverage and financial assistance that can cover dental and housing needs. It has been critical in providing the support needed to achieve undetectable viral loads through medication adherence, which prevents further transmission, also known as U equals U, or undetectable equals untransmittable. At Franny Peabody Center, we see the successful health outcomes that result from this model of care and the strategies that effectively connect people to the resources they need to stay healthy. LD 1115 would apply that same approach of lowering barriers and expanding access to these crucial HIV prevention methods. Maine has one of the highest rates of HIV viral load suppression nationally. We are at the forefront of ending the HIV/AIDS epidemic, but we cannot do it without accessible prevention tools. I urge you to support LD 1115 as it will bring us closer to ending the HIV/AIDS epidemic. Thank you so much, and I'm happy to take any questions you may have.
Any questions from the committee for Ms. Rutherford? Seeing none, thank you for your testimony. And we will go on to the next proponent of the bill, Tiffany Townsend of Maine Health. Welcome. You're muted. Could you please unmute?
Thank you for having me. Good morning.
Good morning.
Senator Sanborn, Representative Tepler, and members of the committee, I'm Tiffany Townsend, a nurse practitioner and an HIV specialist at the Gilman Clinic at Maine Medical Center. I'm here to testify in support of LD 1115. The Gilman Clinic, formerly known as the Virology Treatment Center, was formed in 1991 to treat those affected by the early HIV/AIDS epidemic. In the mid-aughts, we started treating hepatitis B and hepatitis C and the complications that arise from these viruses. Our team includes providers who specialize in infectious diseases, the liver, and addiction, as well as nurses, social workers, a psychiatrist, and pharmacists. We employ an interdisciplinary care model to prevent and treat the complex medical and social needs of our patients. Maine Health and our providers strongly support ensuring a patient's access to HIV prevention medications PrEP and PEP are highly effective at preventing HIV. They are safe, well tolerated, and have few interactions with other medications. Looking toward the goal of eliminating 75% of new HIV infections by 2025 and 90% by 2030, it is critical these medications be widely available and affordable to those at highest risk of being exposed to HIV. The legislation before you today is a tool to help meet this goal by increasing and expanding access to PrEP and PEP, thereby decreasing HIV infections and ending this epidemic. Another benefit of this legislation is that it expands access to care by linking one seeking PrEP or PEP to care, or by increasing engagement for those that may be disconnected from their primary care provider. For those who are a victim of sexual assault when their primary care provider's office is closed, this legislation would allow them to access HIV prevention medications within the recommended 72-hour window and follow up with primary care on the next business day. A pharmacist licensed by the Maine Board of Pharmacy is recognized as an expert of medications and drug therapies. It is within the scope of a licensed pharmacist to dispense PrEP and PEP to patients as outlined in the proposed legislation. I would like to share a patient's story with you. I recently saw a young man in our clinic who reported he had asked his primary care provider twice for PrEP. Both times the provider said they would discuss it at his next visit. Within months, this patient had acquired HIV. Had he had access to PrEP at a pharmacy, he potentially could have been spared from this lifelong chronic and expensive illness. In short, we need to do all we can to remove barriers and expand access to these life-saving medications and act to reduce HIV transmission. The legislation before you today will save lives, prevent severe morbidity, and reduce hospitalizations. I urge you to vote ought to pass on LD 1115. Thank you for your time. I'm happy to answer any questions you may have.
Thank you. Any questions from the committee? Seeing none, we appreciate your testimony. And we'll turn to the next proponent of the bill, Elizabeth Ward Saxel of Mikasa.
Good morning, Senator Sanborn, Representative Tepler, and members of the committee. My name is Elizabeth Ward Saxel, and I'm here on behalf of the Maine Coalition Against Sexual Assault, the organization which represents and serves Maine sexual assault support centers. We are in support of 1115. Each year, 14,000 Mainers will experience sexual violence. HIV post-exposure prophylaxis is one of the possible treatments for survivors of sexual violence immediately following an assault. If a medical provider determines that a survivor is at risk of HIV transmission, a 3 to 5 day supply of PEP is included as part of the free sexual assault medical forensic exam through Maine's ERs. However, we continue to hear from advocates that obtaining and paying for the necessary prescription to complete the remaining course of medication remains a barrier for survivors. In a 2019 survey of sexual assault support center staff, 30% of advocates said that they had worked with a survivor in the past 2 years when there was a barrier to accessing PEP after getting a prescription. Navigating the world following a sexual assault can be ungrounding, overwhelming, and scary. And this bill offers a solution to many current barriers for survivors. Over the years, we have worked with many of the other providers you're hearing from today to find more accessible, affordable, and simpler ways for these most vulnerable to HIV transmission to receive the prevention medication they need. However, more needs to be done. The solutions in this bill address some of the perennial barriers that we have seen that will offer much needed support to survivors of sexual violence. Thank you for your time and consideration, and I'm happy to answer any questions you might have.
Thank you very much. Any questions from the committee for Ms. Ward Saxel? Seeing none, thanks for your testimony very much. And that is the end of my list of proponents who said they wish to speak in favor of the bill. Is there anyone in the queue who would like to speak in favor of the bill? Please use the raise hand function and I will recognize you. Seeing none, is there anyone who would like to speak in opposition to the bill? Again, seeing none, I will call on those I have on the list to speak neither for nor against the bill. Ms. Cook, please join us of Community Health Options.
Good morning, Representative Tepler and members of the committee. Thank you for the opportunity to appear before you this morning. I was hoping I was going after Catherine Pelletreau, who I think has prepared remarks and a fuller description, but this is the tough part about this Zoom testifying, is that sometimes we don't get a choice of when we appear. So I'll do my best. My name is Kim Cook. I'm here on behalf of Community Health Options, and Community Health Options is a nonprofit co-op health plan based in Lewiston, and we are a member-centric organization, and so we exist to provide high-quality benefits to our members. So we are coming in neither for nor against to provide additional information really regarding the sections of the bill that deal with Title 24A, which is the insurance code. As you've heard, I think from one of the proponents, this coverage is required. Community Health Options does cover as a preventative service these medications. And when the United States Preventative Services Task Force determined this course of treatment to be a preventative measure, that under the Affordable Care Act requires this to be covered as a preventative service with no copays, no deductibles, as we call it for the shorthand, first dollar coverage. So although you've heard some testimony this morning from a private citizen about the issues they've had in past years, certainly for a private fully insured health plan, which again is 27% of Maine people have the insurance that you'll be regulating under 24A, that would not be possible today under the law. And so we have no problem with you all, if you so choose, to insert, of course, the requirement that already exists in federal law and really exists in state law, as you all have implemented the requirements of the Affordable Care Act under state law already as well. And I would add that Senator Sanborn raised the issue about the quarterly blood work that is part of the protocol when you're on these medications. We do cover that quarterly blood work also as a preventative measure, first dollar coverage. And so that has, I think, made sure that all of our members are have full access with no barriers to this prevention protocol. And I'd be happy to provide additional information. We were hoping to have our pharmacy director come and speak to you today at the hearing. Thank you, Representative Tepler. I'll be wrapping up. But he was unavailable. He would be very happy to provide additional information to the committee or speak with any members of the committee about how we cover these treatments. As you've heard, there is now a generic, and if I haven't seen the proposed amendment by GLAD, but I am hoping that the committee would simply align with the Affordable Care Act rather than imposing any additional requirements that would require health coverage on first dollar basis for a brand name medication that's being heavily marketed. And we think the having that done as either a step or a prior auth only when it's medically necessary to not have the generic would be the appropriate way to ensure access as well as control costs. So thank you for that.
Thank you, Ms. Cook. I see that Representative Arford has a question, and I have a question as well. Go ahead, Representative Arford.
Thank you very much, Madam Chair, and thank you for being with us, Ms. Cook. Very quickly, I do not know much, if anything, about this. And my quick question is this. This is a safe, I trust all the testimony that we have heard today that this is a safe, efficacious drug. And so I'm just curious as to why blood work is necessary. If this is truly a safe drug, is it to monitor? I don't know. And you may not be the correct person to ask this of either. And I understand that.
Yeah, I'm a lawyer, not a doctor. But from the reading I've done to understand the coverage, and I know this bill was really developed before this became a preventative service as of the beginning of this year. And so, but what I understand for the blood work is that quarterly blood work is recommended based for testing for HIV and other STIs as a monitoring protocol. I'm not sure if there are also, I thought I might have read a kidney function issue as well as a monitoring piece, but I really would recommend that you ask that question of providers or the Maine Medical Association to provide that information. But it is, from our perspective, it's part of the prevention treatment protocol, and hence we cover it first dollar. And really, once the United States Preventative Services Task Force weighs in to say and gives an A rating or B rating, that really is the law of the land, if you will, under the Affordable Care Act. And we are very happy to comply and make sure that that our coverage ensures access first dollar coverage to these services.
Thank you.
Any other questions for Ms. Cook? I have a question that I'm not sure, that really isn't directed to you, Ms. Cook, but is something I'm hoping someone in the attendee list will answer for our work session. And that is about those who are, who have currently been on the brand name medication, and how they transfer to the generic and whether there are any issues there. I'd like to understand the relationship between the brand name and the generic and whether they are actually the exact same medication or whether there are any differences.
I will leave that for others and just refer you all to your standing. I think there's a state law regarding substitution without, as long as a box isn't checked on a prescription to not substitute for a generic, that's allowed, but I don't know the citation on that, and I'd have to leave it to others. There is a bit of a difference between the Truvada and the Descovy. They're both made by the same company, and they're similarly efficacious from a clinical standpoint. One, it has, there's a generic for it, and the other there is not. And the drug company is applying to extend their patent, which of course is going to create a big cost implication if we treat the generic and the other the same in terms of coverage.
Okay, thank you. And I appreciate your testimony, Ms. Cook. I will turn to others who wish to testify neither for nor against, and at your suggestion, we'll call Ms. Peltro of the Maine Association of Health Plans next. Thank you for being here, Ms. Peltro. Please go ahead.
Good morning. My Representative Tepler, members of the committee, my name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans. I see that Senator Sanborn has joined, so good morning to her as well. Kim Cook started to talk a little bit about what I want to get into. Frankly, I don't think there's any dispute about the efficacy of PrEP. And as she said, The plans are all covering it as required. However, there's some complexity under the surface around the particular drugs that I want to share with the committee. There's essentially 3 drugs available. There's Truvada, Descovy, and a newly available generic version of Truvada. So while all HIV prevention drugs may be covered, the generic, which is usually the lowest cost, is going to be covered as a preventive service without cost share under the ACA requirements. But the brand drugs, Truvada and Descovy, are more likely to be covered at a preferred brand tier, unless there's an exception granted to provide those drugs as medically necessary without a cost share. So I'm wary of using up my 3 minutes in the wrong way, responding to a question that was raised. So I'm just going to keep on plugging, and people can ask if they want afterwards. So as Kim mentioned, both drugs are manufactured. Both of the brand name drugs are manufactured by the same company. It's Gilead Sciences, Inc. And they have similar costs. It's about $2,000 for a 30-day supply. For Gilead, this bill keeps their last non-generic PrEP drug on equal coverage footing with the generic of Truvada, which is approximately $1,455 for a 30-day supply. So the concern is that the additional costs associated with preferred coverage for Descovy over the generic version of Truvada will raise costs and actually lower access to PrEP treatment for consumers. So our concern is that this bill would have the effect of requiring health plans to cover Descovy in addition to Truvada and the generic at the same level of cost share, which is as a preventive service with no cost share. Okay, moving along. As you also heard briefly from Kim, Gilead is working really hard to move the market away from Truvada and onto Descovy because the patent on Truvada is running out. In fact, the CEO of the company has spoken publicly about the company's intentions to switch 95% of the patients under treatment with Truvada to Descovy by the 4th quarter of this year. So we urge the committee to look below the surface of this bill and consider the market dynamics underneath the push for expanded coverage of Descovy. Thank you, or Descovy.
Thank you, Ms. Peltro. I see a question from Representative Matheson.
Thank you, Madam Speaker. Thank you, Ms. Peltro. I'm a little confused about 2 things. If you could maybe clarify for me, please. My understanding on the intent of this bill is to cover at least one therapeutically equivalent drug. And so I'm not sure why I'm worried about 3 having to be covered. That's my first question. My second question is, when is this generic medication actually available?
Great questions. The answer to the first one is that the language in the bill refers to one therapeutic equivalent. Now, under Maine law, a therapeutic equivalent is a generic, and I'll read you the definition. It's defined in Maine law as any drug that has identical amounts of the same active ingredients in the same dosage form and in the same concentration that when administered in the same amounts will produce or can be expected to have the same therapeutic effect as the drug prescribed. So it's a generic. The 2 brand name drugs, Descovy and Truvada, are not therapeutic equivalents. They are not generics for one another. They're both used as HIV prevention drugs, but they're applied differently. Truvada is for people at high risk through sex or injection use. Descovy is particularly for people who are at risk through sex, except for people assigned female at birth who are at risk of getting HIV for vaginal sex. They are made of different formulations, so they're not considered generic or, in the words of the bill, therapeutically equivalent. So under this bill, carriers would have to cover both. So is that helpful on the first one anyway?
Ms. Matheson? I mean, Rep. Matheson?
I think so. I'm not sure I agree with that interpretation, but I understand what you're saying.
Fair enough.
Thanks. And I would like to know, Ms. Peltro, I don't know if this is a question you can answer right now, but perhaps someone can answer it for the work session. Are there clinical implications in the differences between these medications? Are there reasons a physician might prefer to put someone on one rather than the other? As I was listening to you, my understanding was that the bill might cover both Descovy and the generic Truvada, but not the Truvada. Is that, how was your understanding different than that?
Yeah, I mean, I'm not 100% on this, so I kind of want to double check with my membership. But my understanding is that the issue is a little bit less around coverage versus coverage as a preventive service. Because if it's covered as a preventive service, there's no cost share at all to the patient. It's covered under the US Preventive Services Task Force guidelines. So the brand names might be covered by the carrier, but not necessarily as a no cost share drug. So that's where it's a little trickier. So let me just stop there. And in terms of the clinical differences, you'll see there's some citations in my testimony to some of the clinical information from the CDC. There are different risk profiles. There are different side effects. And there has been some research done about particular populations for which one drug or the other is not appropriate, particularly around liver disease and kidney.
Thank you. That's helpful. And Representative Morris, did you want to go ahead and ask a question?
I think I have it answered. I'll just more of a clarification. Thank you, Madam Chair. As I'm reading your testimony, Ms. Pelletro, just for the clarification, as I understand it, plans are currently covering PrEP and PEP drugs in the state right now.
Not a simple yes or no.
Okay.
Okay, because those drugs are covered the same way under the ACA that contraceptives are covered. I mean, the ACA provides an A-level rating, or the USPSTF provides an A-level rating for contraceptives. That does not mean that an insurer has to cover every available contraceptive at no cost share. It means they have to cover one. They have to cover one version of each of this. There's 7 types of contraceptives, the pill and all different kinds. But anyway, they have to cover one preparation without cost share. So that's what's typical here too. They're covering one version. It's usually the generic version because that's the lowest cost without cost share. But they're not covering the brand names without cost share. They may provide some coverage, but there's typically a cost share associated with that because it's at a higher tier.
Okay.
So
that's helpful. Yep. No, that's helpful actually.
Any other questions from? Oh, I'm sorry, Representative Arford.
Yeah, thank you very much, Madam Chair, and thank you very much, Ms. Pelletro. Quickly, am I correct in understanding that you just explained that beautifully. The health plans are required by law to provide one medication within every category. However, if for some reason that medication does not work or whatever for the patient, they then can pursue some form of a prior authorization process to be prescribed that drug without any out-of-pocket costs.
Yes, that's correct. In fact, that's required. That to have a process like that is required under the ACA. Consumers have to have the ability to request a different drug for preventive services if it's medically necessary. And under those circumstances, yes, the brand names would be provided with no cost share.
Is there, just to level set and begin to understand the cost of covering this particular pharmaceutical product, is it possible, and I may have missed this in previous questions, but is it possible to be provided with like annual cost to date for all the health plans covering the product that is the chosen product, and then also those that have been issued through a prior authorization process? Do we have access to that type of information, or is that privileged information?
I doubt it's privileged. It's just a job to pull that together.
Okay.
And I also think it might be, that's a question that might be more complicated to answer than you might think because of the different types of products available. So, you know, we'd have to carve out the right population. I can certainly go back with it, Representative.
So for right now, I'm going to withdraw that. I'm going to sit with that for a minute because we may also get some information from the superintendent of insurance on this. That is whatever. But thank you so much for being with us today. I really appreciate it.
Any other questions for Ms. Peltro? And I will mention that the superintendent of insurance has submitted written testimony, but was not, at least as far as I know, planning to testify in person today. So, or as a spoken testimony. And I don't see, although there are members of the Bureau of Insurance on the list, I don't think any of them were slated to testify on this. But we do have two more people who are testifying neither for nor against. First up is Sam Hollemeyer of PCMA.
All right, thank you, Madam Chair. Hello, good morning, everyone. My name is Sam Hollemeyer. Good morning, Chair Tepler, Chair Sanborn, members of the committee. I'm here on behalf of the Pharmaceutical Care Management Association, otherwise known as PCMA, and I'm here to provide comments as neither for nor against LD 1115, which is the HIV preventative medications bill. Again, PCMA is the National Trade Association representing pharmacy benefit managers, otherwise known as PBMs, which administer drug plans for millions of Americans with health coverage. I really appreciate the opportunity to provide comments this morning on LD 1115, and in fact, applaud the legislator and bill sponsor, Senator Sanborn, to provide coverage for an enrollee for HIV prevention drugs at the lowest cost share. This is a great initiative for the state to help prevent a terrible disease that has impacted so many individuals and families. Those that have testified before me have shared most of my comments, so I'll keep this brief. I would, however, request that we amend some of the language in section 4, subparagraph 3, for the ability for carriers to still be able to perform step therapy and prior authorization based on clinical evidence and rationale. Again, those were mentioned before me, those that testified before me. In the case of making PrEP available at the lowest cost share, prior authorization may be needed as an operational trigger, as well as controlling costs by suggesting that patients start with the lower cost option, which is the generic Truvada, again, to help control drug costs in the state. Again, I'd like to thank the committee and bill sponsor's intent for improving patient care in Maine, and we suggest the committee consider our proposed amendment. I want to thank you for the opportunity to speak this morning again, and I'm here to help answer any questions.
Thank you, Mr. Hallmeyer. Any questions from the committee for Mr. Hallmeyer? I have one brief question, Mr. Hallmeyer. When you refer to step therapy, are you referring to an annual process, or are you referring to a one-time only approach to the medication?
Step therapy processes are typically designed by the plans, not the PBM. So it is up to the plans on how they determine how often those step therapies are reviewed.
Okay, because if someone has been on the generic Truvada and it doesn't work comfortably for their particular clinical presentation, and they move to one of the non-generic medications, then if they're required annually to go back and try the other medication, that can be problematic.
Completely understood. Thank you for the question, Madam Chair. Typically in those situations, the doctor or the prescribing physician would start that prior authorization process before having to go back to the previous medication. So I hope that helps answer your question. So we wouldn't suggest patients go back and start on the old drug again. The prescribing physician can start that PA process before the plan year is up, or whatever arrangement a plan might have.
All right, thank you. So it would require an annual prior authorization to keep the patient on the preferred drug.
Madam Chair, again, it's up to the plan. It's not always annual. It's up to how the plan designs their setup when it comes to prior authorizations. Typically, I believe it is a year though.
Senator Sanborn just reminded me that actually step therapy can't be done annually in Maine. We had passed a bill on that, I believe in the 129th. So
excellent.
Thank you. All right. Seeing no other questions, no hands from the committee, thank you for your testimony. And we'll turn finally to Christine Ossenfort, also speaking neither for nor against the bill.
Good morning, Representative Tepler, Senator Sanborn, and members of the Health Coverage Insurance and Financial Services Committee. I am Christine Ossenfort, Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I am here before you this morning to testify neither for nor against LD 1115. As others have noted, the U.S. Preventative Services Task Force does require coverage of PrEP and PEP as preventive services at zero cost share. So we would agree with the recommendation of some of the proponents that the bill be amended to reflect that requirement rather than addressing cost share tiers. We are concerned with the restrictions on prior auth and step therapy. For use in as a preventive measure, those drugs are not subject to prior authorization, but they sometimes are used also in the treatment of HIV and may be used in combination with other drugs, and sometimes that may be subject to step therapy. Also, eventually, we hope other drugs will become available, so it may be appropriate to preserve the ability for prior authorization and step therapy to be used in the future as there are more coverage alternatives and more is known about the drugs. In response to Representative Arford's question about cost information, this is a fairly new recommendation of the Preventive Services Task Force, and I believe it took effect in 2021. So right now we have very limited experience with that. We're only looking at 3 months of experience with the requirement. So with that, I'd be happy to answer any questions that you may have, and will of course be present at your work session as well.
Thank you very much, Ms. Ossenfort. And any questions for Ms. Ossenfort from the committee? Seeing none, thank you for your testimony. And that brings to an end my list of folks wishing to testify neither for nor against the bill. So I will turn to our attendee queue and see if there's anyone else who would like to testify neither for nor against the bill. And look for electronically raised hands. Seeing none, I'll bring the hearing on LD 1115 to a close, and we will move on to LD 1150 and open a hearing on that bill. And I believe we're also going to switch chairs again.
Thanks, Representative Tepler. And I thought we would take a 5-minute break, but let's just take a 4-minute break until 11:45, and then we'll start the next hearing.
Sounds good.
Okay, it is 11:45. If folks could turn their cameras back on, we will continue with our morning. Again, it's 11:45, so if our committee members are back, they could just pop the camera on quickly so I know you're here. Great. And we will open a public hearing on LD 1150, which is an act to eliminate insurance rating based on age, geographic location, or smoking history, and to reduce rate variability due to group size. And it is presented by our own Heidi Brooks. And so I will ask Representative Brooks to present her testimony for us. Go ahead.
Thank you. Good morning, Senator Sanborn, Representative Tepler, and members of the Health Coverage, Insurance, and Financial Services Committee. My name is Heidi Brooks. I represent House District 61, which is part of Lewiston, and serve alongside of my colleagues on this committee. Maine has been a leader in patient protections with health insurance. As a state, Maine recognized that requiring coverage for pre-existing conditions and not allowing caps in healthcare insurance were important measures. With the passage of the Patient Protection and Affordable Care Act, the states that didn't have these important policies benefited greatly from these measures. Similarly, the policy of rating patients in health insurance is problematic. Mainers who are older, living in rural parts of the state, and have substance use disorder of smoking can be charged higher rates for health insurance. Currently, the Patient Protection and the Affordable Care Act limits how much more insurance companies can charge older patients by a factor of 3 to 1. And this committee passed legislation to limit this rating factor to 3 to 1 last session to ensure this protection in Maine. Rural areas, rural Mainers can have up to a 1.5 to 1 rating system, which would cost more, 1.5 times more than 1. And smoking can also have a factor of 1.5 to 1. With age and geographic variations in premiums, some of these rate increases can be covered by the subsidies of the Patient Protection and Affordable Care Act. However, some of our most vulnerable, older, and rural Mainers are unable to afford coverage. Rating insurance coverage increases for smokers is not covered by the Patient Protection and Affordable Care Act subsidies, leaving more Mainers out. Previously, Maine has had problems with this approach, which will be described in more detail by opponents of this bill, where younger, more urban people left the market due to costs. With many losing their health coverage with job loss during the coronavirus crisis, we were fortunate to have the Maine Care Expansion and Patient Protection and Affordable Care Act available to many, and open enrollment also expanded was helpful. This bill has been brought before this committee and previous legislators. The health coverage, at first I was unfamiliar when I came to this committee about insurance and practices in insurance. With the rating factors, it can be significantly more expensive for people that are most vulnerable. And I've heard it referred to as discrimination as well. And I would think that healthcare would be delivered a little differently than different than some other types of insurance. With a medical background, we're mostly focused on treating a person, and if a person doesn't have access to healthcare, there's great suffering. And also, when they do get healthcare that they need, there is a lot of cost because of preventative measures and other healthcare needs and medically necessary needs have not been covered for quite a while. So when people finally get the opportunity to see a healthcare provider and not have to try to choose between very expensive medical bills and eat what they're going to eat, what their housing situation is, it's extremely difficult choices for people to make. And medications are another important factor, that if a provider and a patient come to an agreement on medication that will help them, that will prevent diseases or treat diseases either earlier or later in life, not being able to afford it is a major, major barrier. And the market-based solutions can make things worse, or they could be stepping in the correct direction, like with having having more people covered or not. There's also a substantial number of people that are covered, but it's still not affordable because they're still with high deductible plans, especially, or high copays. They're still not able to afford that much needed health care. So although this bill in this approach to have community rating and guaranteed issue where people can get health insurance has been challenging in the past, it's a challenge that we must face. And I would be hopeful that this policy consideration would be discussed and worked upon. I thank you for your consideration of this bill, and I will end my testimony there, and we'll try to answer questions that you may have.
Thank you, Representative Brooks. Are there questions for the sponsor of the bill? I don't see any, so we appreciate your testimony. Are there any additional members or attendees in the Zoom who wish to testify in favor of the bill? Please raise your hand at this time. All right, seeing none, we'll turn to testimony in opposition to the bill. And I will just note that Mr. Allenbaugh messaged us to let us know that he would stand on his written testimony. So you can find that in our online files. And I will call Mr. Yardley from the Maine Bureau of Insurance to testify. Good morning, Mr. Yardley. Go ahead.
Thank you, Senator Sanborn. Good morning. Good morning, Representative Tepler and other members of the committee. My name is Ben Yardley. I'm Senior Attorney at the Bureau of Insurance. Superintendent Chappell is unable to attend this morning's hearing because of a conflict and sends his regards. I have submitted testimony. It goes on for several pages. I won't read it. I will summarize that we are concerned about the substance of the proposal and the timing for implementation. I would note that the federal ACA permits variations based on age, tobacco use, and geographic location. And as Representative Brooks mentioned, there had been a prior experience in Maine with community rating that was more stringent, that did not turn out very well and led to you've heard the term death spiral. This is before my experience with the Bureau of Insurance, so I don't have firsthand knowledge of that. We also have available Marty Hooper, who's the Bureau's life health actuary, who have questions. We will be attending the work session, but glad to try to answer any questions that you have now. And with that, I will close my testimony.
Thank you, Mr. Yardley. Are there questions for Mr. Yardley? Okay, seeing none, I will next call Ms. Pelletreau to testify. Good morning still, Ms. Pelletreau, go ahead.
Good morning, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to testify in opposition to this bill. First, I wanted to provide just a little bit of history. In my time, I think that this is at least the third time that this identical bill has been brought forward. And it comes from a laudable place of trying to lower costs for consumers. However, this is a major, major change to the current health insurance market. I mean, we align very closely with what the Bureau has said just before me from Ben Yardley, but also their opposition testimony, both of the last times that this bill came up. As you've heard, Maine has quite a history with the rating factors. And if you did decide to go forward with something like this, it bears very serious study because it will have a dramatic effect. I'll stop there. Thank you.
Thank you, Ms. Pelletreau. Are there questions for Ms. Pelletreau? All right, seeing none, I'll next call on Ms. Ossenfort to join us again. Ms. Ossenfort, welcome back, and go ahead.
Thank you. Good morning, Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. I am Christine Ossenfort, Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, and I appear before you this morning to testify in opposition to LD 1150. As Mr. Yardley noted, the bill is inconsistent with the provisions of the Affordable Care Act, which does allow rating based on age, geography, family size, and tobacco use. Group size is no longer permitted under the ACA. I believe it may be on the books still for the possibility of grandfathered plans, which would not be subject to ACA rating requirements if there's still any in existence. We previously combined group size with age, so it's a combined rating factor if it is allowed to apply at all. As Mr. Yardley also noted, Maine has previously experimented with a move to strict community rating, which means you cannot rate based on age or geography or tobacco use. And they actually stopped that movement because it was driving younger, healthier folks out of the marketplace. And you would see that dynamic occur again if you were to move in that direction. And finally, we would note that if this was something that the committee was interested in pursuing, you really should include some sort of transition. If you transition immediately to eliminating those rating factors, you will see a significant rate shock, particularly for younger individuals. So with that, I'd be happy to answer any questions that you may have, and will, of course, participate in your work session as well.
Thank you, Ms. Ossenfort. Are there questions for Ms. Ossenfort? Okay, seeing none. Next, I will call on Mr. Garrity. Good morning still, Mr. Garrity, go ahead.
Good morning, Senator. Senator Sanborn, Representative Tepler, members of the committee. My name is Bruce Garrity. I'm here on behalf of the Maine Automobile Dealers Association Health Trust, which is a MEWA. I really don't have anything to add given the completeness of the testimony already, so please, I'd be happy to answer any questions, but I really think the issues have been covered pretty well. Thank you.
All right, thank you, Mr. Garrity. Seeing no additional folks who are signed up to testify, I will give a last call for anyone who is in our Zoom who wishes to testify verbally on this bill. And seeing none, I'll close the hearing on LD 1150. All right. And a work session will be scheduled likely for next week on LD 1150. So with that, we're going to roll directly into the next bill, which is 1151, an act to lower out-of-pocket prescription medicine costs by requiring health insurers to offer plans with no deductibles. And I see that the sponsor of the bill, Representative Collins, is in our meeting, so we'll invite him in to join us to present his bill. Good afternoon, Representative Collins. We can't see you yet, but if you want to start your video and begin, that would be great. Good afternoon, go ahead.
Good afternoon, can you hear me?
We can. And now we can't. You seem to have frozen a bit for a minute. So if you want to start over, that would be great.
Okay, thank you. I was having a problem earlier.
Representative Collins, if you want to turn your video off, and it seems you might be in the meeting twice now, so that could be an issue. But if you want to turn your video off and testify just verbally, that might help you to stop from freezing. And this also highlights the need for better broadband, even in the city of Portland. So go ahead, Representative.
You don't want to, if you don't want to see my face, I'll get off the video here. Hold on, let me see. All right, am I on? Can people hear me?
Yes, we can hear you smoothly now. Go ahead.
Okay, great, thank you. Yes, I am Representative Benjamin Collins. I represent a part of the city of Portland, House District 42. I used to serve on this committee, which seems like many years ago, but I think it was only 4. And of course, would I be there in person, I would bring you lots of delicious donuts from Portland. But when you are back in person, I will bring every committee member and staff at the committee some good donuts. So originally I am from Fort Kent now. Originally I am from Fort Kent, but I'm glad to see that there is another person from Fort Kent who's now represents Buxton on the committee. So I know you're well served. So this bill goes at an issue which we're all very well aware of, the high costs of people paying for prescriptions, and even in negotiated healthcare plans, costs can be exorbitant. I think this was very much highlighted recently when the University of Maine system almost changed their healthcare plan, and some staff talked about how high the change would make their healthcare costs be, specifically pharmaceuticals, with one retired staff member from the university system saying she would have to pay over $800 a month for life if the plan was changed. Luckily, the state decided not to change the plan, which was great relief for many of our retired university staff. So that's just one example. And what this bill would do, and it would require some options in a healthcare plan to offer not having that deductible for pharmaceutical costs. And from my recollection, being on this committee years ago, just reports back from the state, so much of a person's deductible is their prescription drug costs. I don't know to what extent specifically. I don't know if the department, the Bureau of Insurance has that, but it is a very high percentage of people's deductibles often. And for some people, specifically with rare or very severe illnesses or diseases, the costs are astronomical and are such a burden to so many people. So I would like the committee to look at this, and I'm hoping that the Bureau of Insurance can work with the committee to at least study this issue further in some form, whether it be a study commission or through a work group, to look, number one, what the costs would be to healthcare plans if this went through. I remember in the past, of course, and I probably, I say this somewhat in jest, but in reality, I probably can tell you what lobbyists representing healthcare companies are going to come up and speak about this bill and what they're going to say, just having heard them speak on bills like this when I was on this committee. And what you'll hear some of them say is that this will cause rates to go up for consumers, and that was a reason used on many bills to try to not allow changes to take place. But some changes did take place, and I think the sky really didn't fall. But with that being said, I would encourage involvement with the committee, the superintendent of insurance. I think you should also have the superintendent Chapa's office have consumers involved that have very high prescription drug costs be involved and speak with you and the superintendent to find out exactly what the costs might be, how it could be absorbed by the plans, and also look at the fact that in many healthcare plans, when there's a negotiated rate on pharmaceuticals, there's a savings that happens, there's a discount that happens, but oftentimes the consumer pays that full amount and the difference is pocketed by the healthcare plan. So I think that also could help lower the rates. So those are some things I hope the committee would consider and look at. And most importantly, just consider the great burden that many consumers have with exorbitant costs with their healthcare plans going to pharmaceuticals. With that, I would be happy to answer any questions. I understand the Bureau of Insurance will speak on this. They didn't have a chance to speak with me before this bill, but I am going to speak to them further before the work session, and I hope we can allow input from consumers as well. So thank you very much to Senator Sanborn, Representative Tepler, and distinguished members of the committee. Happy to answer any questions.
Thank you, Representative Collings. Are there questions for Representative Collings? All right, seeing none, we thank you for presenting the bill to us today. And I will first call Mr. Yardley from the Bureau of Insurance to testify. I guess first, before I do that, I should ask whether there's anyone else in the Zoom meeting who intends to testify in favor of the bill. And seeing none, we'll turn to those who are registered to testify in opposition to the bill and call Mr. Yardley to join us. Thank you, Mr. Yardley. Go ahead.
Senator Sanborn, Representative Tepler, and distinguished members of the Health Coverage, Insurance, and Financial Services Committee. My name is Ben Yardley. I am Senior Attorney at the Bureau of Insurance. As you know, Superintendent Chapo was unable to attend today's hearings. We did try to speak with Representative Collings, and unfortunately, as you probably know, we're at a hectic time of the legislative session and we're unable to do so. Our concerns are brief. We are concerned about the impact of this bill on metal levels and calculating actuarial values and the potential for premium increases. These are issues that we have heard as we have attempted to work through the clear choice provisions of LD 2007 from the previous legislature. These are comments that have been raised by insurers. As you know from the previous hearing, actuary Marty Hooper is with me, and we'd be happy to try to answer any questions here or at the work session. Thank you.
Thank you, Mr. Yardley. Are there questions for Mr. Yardley? All right, seeing none, we thank you for your testimony. And next, I will call on Ms. Pelletreau to join us again. Good morning, Ms. Pelletreau. Go ahead.
Good morning, Senator Sanborn, Representative Tepler, members of the committee. My name is Catherine Pelletreau. I'm the Executive Director of the Maine Association of Health Plans, and I'm here to testify in opposition to LD 1151. My testimony kind of follows along with where the Bureau is, so I won't repeat all that. I'll just put a very fine point on it, which is that deductibles are an important tool. And they don't do anything to reduce the underlying cost of care that drives premiums. So to be able to get at the overall cost of healthcare, there has to be a better understanding and analysis of the underlying cost drivers that drive healthcare costs. This bill would require 50% of the plans that a carrier offers to have no deductible for pharmaceutical drugs. It's not consistent with high deductible health plans and health savings accounts, and it's not compatible with the clear choice plans, the standardized plans that the state is in the process of moving forward with now. Thank you.
Thank you, Ms. Pelletreau. Are there questions for Ms. Pelletreau? Seeing none. Next, we will call on Ms. Ossenfort. Good afternoon, Ms. Ossenfort. Go ahead.
Thank you. Good afternoon, Senator Sanborn, Representative Tepler, and members of the Health Coverage Insurance and Financial Services Committee. I am Christine Ossenfort, Director of Government Relations for Anthem Blue Cross and Blue Shield in South Portland, Maine, and I appear before you this afternoon to testify in opposition to LD 1151. I won't repeat what you have already heard. We would echo the comments by both Mr. Yardley and Ms. Pelletreau. It is expensive. It does make it difficult to achieve actuarial value and potentially increases the cost sharing for other services covered under the plan if we were to have to do this. And I would finally note, as the committee is well aware, this would not apply to Medicare Advantage plans. It would not apply to self-funded plans. So with that, I'd be happy to answer any questions that you might have and will participate in your work session as well.
Thank you, Ms. Ossenfort. Are there questions? All right, seeing none, we thank you for your testimony today. Mr. Garrity was originally signed up to testify verbally on this, but has let us know he didn't want to do so. So with that, I believe we've reached the end of my registration list. If there is anyone else in the Zoom meeting who wishes to testify on this bill, please raise your hand at this time. Seeing none, I'll close the hearing on LD 1151, and a work session will be scheduled likely for next week. With that, we have completed our morning's public hearings, and we will be holding work sessions this afternoon starting at 1:30. And for folks in the Democratic caucus, we'll be caucusing at 12:30. Are there any other announcements?
Yes,
Ahead,
thank you, Madam Chair. Yes, thank you, Madam Chair. House Republicans, I will send you the meet invite right now.
All right. Thanks, everybody. We'll see you this afternoon. Okay, welcome back, folks. I think we have more than 8, so we're good. So we do have a series of work sessions this afternoon. Let's see, I think I'm going to run them a little bit out of order here. So we will start with LD4. An act to amend the Maine Pharmacy Act. And Colleen, I think your analysis is pretty brief, so why don't we... Oh, maybe I've jumped the gun and Colleen isn't there yet. Okay, well, we will wait for Colleen to get back from lunch or to join us so that we can look at that. I think it may be possible for us to do some of these without Colleen's assistance potentially, but she usually takes notes on our work sessions, so I don't want to jump ahead of her. There she is.
No, I'm here, but I was having some sort of technical difficulties. I don't know if I can get my video on, but I got my audio finally.
Okay, perfect.
Sorry about that.
No worries. I was just worried that we'd lost you for a bit.
No, but I am like, I don't know what is going on with my screen. So I
can screen share if you need me to. I have everything open if you need me.
Okay, good. I have everything open, but for some reason, I can't even do this, find the screen share. I don't know what is going on in I only see one of you and it's like cutting off the rest of your view on my computer for some reason. So.
Okay. Well,
I was just going to say, we're all replaceable, but Colleen really is not.
No, that is true.
I am.
It's a good point, Representative Morris. So Colleen, do you want me to try and share my screen?
That would be great. I'm happy to go through it.
Okay. All right. Can folks see my screen?
Yes.
Okay, great. So Colleen, go ahead.
Okay, so I'll go through it, and then when I'm ready to swap the screen, I'll let you know, because I can't see the shared screen, but I can pull it up on my own document.
Okay.
I can walk through it.
Okay.
And we're going to start with 4, right?
Yes.
Okay, so LD4, this is a bill that was introduced on behalf of the Board of Pharmacy, and it makes a number of changes to the Maine Pharmacy Act that are listed here. One, it clarifies the responsibility of the pharmacist in charge of a pharmacy. It repeals the character reference requirement for licensing. It contains a provision that would update and clarify requirements for a process called licensure by endorsement. It changes and updates the timeline for certain reporting requirements to the Board of Pharmacy, and it eliminates the requirement for submission of a vaccine administration treatment protocol to and for approval by the Maine Board of Pharmacy, and instead it would require pharmacies to maintain a copy of that protocol on their premises and provide it to the board upon request. And I did provide a link in the analysis to the written testimony. So I'm ready for the next page. One of the issues, particularly with regard to Section 5 of the bill related to licensure by endorsement, as I mentioned, that section would provide authorization for licensure by endorsement, and it would provide the ability for pharmacists who are licensed in other states or educated and trained in other countries to become licensed in Maine. The bill before you is specifically drafted to the Board of Pharmacy, but I wanted to make you aware that there is a bill being considered by the IDEA Committee that the department as a whole has introduced that would provide similar authority to all boards licensed by the department's Office of Professional and Occupational Regulation. And it provides a pathway for licensees, not only from the Board of Pharmacy, but from other licensing boards to be licensed in the state. So one of the things the committee might want to consider to avoid any conflict or potential for inconsistency between the two bills. And it was suggested by the department that you might want to consider removing Section 5 of this bill as drafted. And you could add a cross-reference to those statutory provisions that are expected to be enacted in LD 149. I should tell you that the IDEA Committee is working LD 149 together today. So they haven't taken a final vote on that bill, but they are expecting to move it forward. With regard to that section, you did have some testimony from the New Mainers Resource Center suggesting an amendment to the section as drafted related to requiring proof of a valid license. And they noted that some asylum seekers or refugees may not be able to satisfy the requirement as drafted, and suggested some changes. So I would note that the language in LD 149 would accommodate this situation. So if the committee does defer to the language in 149 as suggested above, there would not be a need for any additional amendment to the language.
Okay.
And then lastly, there was a suggested amendment from the pharmacist representing Northern Light Health to section 6 of the bill, which relates to making changes to the requirements for pharmacists in charge. And they provided information that they currently have a waiver from the board that allows hospitals operating within that system to have a common pharmacy leadership and recognizes the pharmacist in charge in more than one location. So they had suggested being allowed to continue under those waivers. The board, the language in the bill as written references determinations by board rule. And I would note that Ms. Betts I believe, from the pharmacy board should be here and could answer some questions, but my understanding is the board is currently in the process of updating their rules. And the expectation is that in that rule as adopted, it would provide the flexibility for this type of situation to be addressed without a requirement for a statutory change. So if the committee wants to hear more about that, Ms. Betts can bring you up to date on the rulemaking process. My understanding is they are trying to sort of move this bill and the rulemaking process sort of in concert together. And then lastly, the fiscal information, any additional costs to the board can be absorbed within their existing resources if you move this forward. That's LD4.
Thanks, Colleen. Let's quickly hear from Ms. Betts, just so that we know we don't need to address that issue. Christian, if you'll bring her in. Oh, there's Colleen.
I can start my video now. Still can't see the screen.
Good afternoon, Ms. Betts. Thanks for joining us.
Good afternoon.
Good afternoon. Yeah,
Do I sound better today than I did in the past?
You do. You're very clear today. Thank you.
Great. I'm so apologetic for being so fuzzy last time.
That's all right. So our question, I think, is about the timing situation. We want to make sure that Northern Light doesn't get into a situation where they are not able to continue operating as they do today with regard to pharmacists in charge. So can you give us a sense just on the timing piece of whether this could create an issue if we don't account for it in the statutory language?
The board has spent, Senator Sanborn, thank you. The board has spent a considerable amount of time, actually years, redeveloping the full scope of their 200 pages of rules. And we are at the stage where we are in pre-legal review of a finished document. And within that, the board has proposed to change the requirement where a pharmacist in charge could be in charge of multiple pharmacies, not just one, and without requesting waivers for each separate time that happens. So the criteria would be just to go ahead and, any pharmacy could charge a pharmacist in charge at will. If that pharmacist in charge is not available, could name another pharmacist, such as a pharmacist on duty, to act as a pharmacist in charge. The pharmacy has to make sure that that person will take on the responsibilities of what a pharmacist in charge does. There would be no requirement to report it to the board at that time. There would be no requirement to obtain a PIC change or file an application with the board. They can at will do it. Only if what is being proposed, should there be an extended period of time that the original pharmacist in charge, as reported to us, becomes unavailable, then that new pharmacist in charge would then be reported to us, not to seek waivers, but reported as an entirely new pharmacist in charge of the pharmacy and what's on record here in our office. Does that help?
Okay. Yeah, it does. Are there any questions for Ms. Betts? Okay. Seeing none, thank you.
Senator Sanborn?
Sure, go ahead.
We
Yeah.
certainly hope to go to rulemaking. In other words, to formally advertise the rule and accept public comments, hopefully within the next couple of months. So we're looking at something very quick here, hopefully. Thank you.
Okay. And these are routine technical rules? Ms. Betts?
Yes, they are.
Okay, great. That's all the questions I have for Ms. Betts. Does anyone else have any questions? Okay, thank you for joining our work session today, Ms. Betts.
Thank you.
So with that, are there any comments on the bill? All right, seeing none, I'm going to entertain a motion. Representative Tepler, go ahead.
Thank you, Chair. Yeah, I got it. Sometimes it takes 2 clicks on the button as you move around on the screen. I would move ought to pass as amended, both by the cross-reference to LD 149, which is the Omnibus Professional Regulation Bill, and I'm uncertain whether I need to include, based on Ms. Betts' testimony, okay, I do not need to include the Northern Light Amendment because that will appear in routine technical rules in the near future. Okay, so just the one section amendment ought to pass as amended.
Yep. Is there a second? Representative Quint has seconded. And I'll just make a note that for the committee that we would hold this bill in committee. So we will have voted it, but we'll hold it in committee until the cross-reference becomes valid, which would require that LD 149 be passed first. So we'll make sure that we're sequencing, and we'll lean on OFPR and the revisor's office to sequence the bills appropriately so that we create a valid cross-reference. But I anticipate that won't be too tough to do. So I just did want to flag that for the committee. Is the committee ready for the question? Okay, the clerk will call the roll. We can't hear you, Christian.
What do you know? Representative Quinn.
Now we can.
Yep. Yes, you can.
Yeah. And so yes.
Representative Quinn. Yes. And yes, even I leave my mic muted. Representative Connor.
Yes.
Representative Connor. Yes. Representative Blyer.
Yes.
Representative Blyer. Yes. Representative Morris.
Yes.
Representative Morris. Yes. Representative Matheson.
Yes.
Representative Matheson. Yes. Representative Evans. Representative Evans is absent. Representative Arford.
Yes.
Representative Arford. Yes. Representative Millerano.
Yes.
Representative Millerano. Yes. Representative Brooks.
Yes.
Representative Brooks. Yes. Senator Stewart is absent. Senator Brenner.
Yes.
Senator Brenner. Yes. Representative Tepler. Representative Tepler, you're muted.
Yes.
Representative Tepler. Yes. Senator Sanborn.
Yes.
Senator Sanborn. Yes. That is 11 yes to absent.
Great, thank you, Christian. All right, so next, let's pick up LD 998. Colleen, are you able to work
I can't
to share
I don't know why.
yet? Okay.
Yeah.
Let
If you don't mind
me
sharing
find
it, this one will
yeah,
be quick.
this one's super quick. I'm not even sure we need it, but I will share it really
I know.
fast.
I could verbally do it without the sharing.
All right, you guys should be able to see that.
Just real quickly, LD 998 is a bill sponsored by Representative Tepler. It would make some changes to the continuing education requirements for pharmacists. It would amend the law governing their continuing education pharmacy credits by providing that only pharmacists who are authorized to administer drugs and immunizations are required to complete at least 2 hours in board-approved courses on drug administration. Under current law and Board of Pharmacy rules, all licensed pharmacists must complete at least 2 hours of their 15 hours total of continuing education in board-approved courses on drug administration. This bill would remove that requirement for those pharmacists who are not certified to administer drugs and immunizations, but it wouldn't reduce their overall requirement for 15 hours of continuing education credit. They would be able to focus their CEs in different areas. And then just noting for you from the Board of Pharmacy, their data that there are currently a little over 2,300 pharmacists licensed in the state, and a little over 1,300 of them are currently certified to administer drugs and immunizations. So around 1,000 pharmacists would be affected by this change if you move it forward, and then minor cost to the Board of Pharmacy to implement these requirements. You move forward.
Thank you, Colleen. I'm going to stop sharing. And I will just note that I found it very important when considering this bill that the pharmacists who would be no longer required to take these CEs are literally not allowed to administer drugs or immunizations pursuant to their license. It's not just that they don't do it as a matter of practice, it's that they're not allowed to do it because it's not part of their license. So that was a really important distinction for me in getting comfortable with this bill, which I think after you realize that piece is an easy pass. So are there any other comments on the bill? Senator Brenner?
I was just going to make a motion.
Great, I'll take a motion.
Yeah. I vote we ought to pass.
Is there a second?
Second.
Representative Connor has seconded. Is there any further discussion on the bill? Seeing none, the clerk will call the roll.
Representative Quint?
Yes.
Representative Quint, yes. Representative Connor?
Yes.
Representative Connor, yes. Representative Blyer?
Yes.
Representative Blyer, yes. Representative Morris?
Yes.
Representative Morris, yes. Representative Matheson?
Yes.
Representative Matheson, yes. Representative Evans? Representative Evans is absent. Representative Arford?
Yes.
Representative Arford, yes. Representative Melorano?
Yes.
Representative Melorano, yes. Representative Brooks?
Yes.
Representative Brooks, yes. Senator Stewart is absent. Senator Brenner?
Yes.
Senator Brenner, yes. Representative Tepler?
Yes.
Representative Tepler, yes. Senator Sanborn?
Yes.
Senator Sanborn, yes. That's 11 yes, 2 absent.
Great. Okay, next we'll go to LD 790.
I can't answer.
And I can share that.
Thank you for sharing.
Yep.
And I would note, I don't know what happened. Some of these were saved and they might open with a different title, but the actual, something was embedded in the PDF that it might show that it's LD 443, but it really is 790. So LD 790, this is a bill to clarify a law that was enacted last session related to patient consent for certain medical examinations. Under the current law, a healthcare practitioner may not perform a pelvic, rectal, or prostate examination or supervise that examination performed by an individual practicing under their supervision without first obtaining a patient's specific informed consent, both verbally and in writing, to that examination, except in two situations. One, in the case of an unconscious patient, the examination would be required for diagnostic purposes and is medically necessary, or the healthcare practitioner is authorized to perform a forensic examination on an unconscious alleged victim of sexual assault. What LD 790 proposes to do is to add a third exception, clarifying that written informed consent is not required for pelvic, rectal, or prostate examinations performed on a conscious patient in such cases, the informed consent must be obtained verbally. I linked to the testimony if you're interested, but I would note, and as mentioned at the public hearing, this is a provision in law that was enacted last session during the 129th legislature. It became law in March of 2020. Representatives of hospitals and other providers brought the bill forward to clarify that verbal informed consent would be sufficient before performing one of these examinations on a conscious patient. And they raised some concerns that obtaining written consent can sometimes be a burden when one of these exams is not anticipated as part of a patient clinical visit. As drafted, I would note that the bill would remove the requirement to obtain a written consent in all cases for a conscious patient for one of these exams. So I didn't know if the committee wanted to consider whether to narrow the scope of the circumstances for when the verbal or oral consent is sufficient. And lastly, we don't yet have the fiscal information, but I would anticipate it would be minor costs that can be absorbed.
Okay, is there discussion on the bill? Is there a motion? Senator Brenner.
I make a motion to pass the bill as written.
Representative Tepler.
Thank you, Madam Chair. I just was wondering what kind of circumstances Ms. McCarthy-Reed was thinking about that would be important to consider in narrowing the scope of the bill.
My only suggestion was that if you thought that written consent was important in some circumstances, like before an annual exam, or that where someone would be expecting this to happen, you thought there would be a need to have both verbal and written consent. And then when I was suggesting about narrowing the circumstances, it was just in the case of an unconscious patient where it would be part of the clinical visit, more tied more closely to what the circumstances or the issues that the provider representatives identified as when this would be appropriate. The other examples or the other current exceptions in law for when verbal and written consent would not be necessary when someone is unconscious, it is limited to those situations where it's for diagnostic purposes and is medically necessary, or in the case of an alleged victim of sexual assault. And then in all other cases, there would be a requirement to get advance written and verbal consent. And so that was my only consideration that I was raising for the committee, because this would be a broad exception for in all cases.
And prior to the bill coming forward in the last session, there was no requirement for written consent.
There was no statutory, specific statutory requirement, although I think as you're probably aware, it's a common practice.
Ethical standard.
Yeah, for informed consent to be provided, and practitioners commonly will get that in writing.
Okay, my antenna went up when you said that, and I was wondering if there was some other circumstances, I don't know, intoxication or something we should be considering.
Is there a second for the motion? Representative Brooks has seconded the ought to pass motion. Is there further discussion? Representative Morris.
Yes, thank you, Madam Chair. I just wonder if on this specific bill where it was brought forward and it's the way it's being done now, if we would need to put an emergency on this or if we're good to wait. Just a question.
Yeah, that's a fair question. I think it would be fine with an emergency, just to be clear that we want to fix this this glitch. Colleen, do you see any issues with that?
No, and it actually, given the uncertainty of there's no statutory adjournment associated with a special session like there is in a regular session. Maybe it's even more even more of a consideration to think about, because, in the normal course, then it wouldn't be, without an emergency, it wouldn't become effective until 90 days after the special session adjourns. And we don't actually know when that will be, although I think you hope it to be closely aligned with the statutory adjournment for our regular session, but you never know. So
I sure do. Okay, thank you, Colleen. Yeah, so Senator Brenner, would you add an amendment, a friendly amendment of an emergency clause on your motion?
Yes, thank you, Representative Morris. That's a great idea.
And Representative Brooks, do you second that? Great. Senator Brenner, did you want to say something else?
I'm just wondering what Ms. McCarthy Reed has planned in late June.
All right. Seeing no further discussion, the clerk will call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans. Representative Evans is absent. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
Yes.
Representative Melorano, yes. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart.
Yes.
Senator Stewart, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 12 yes, 1 absent.
Okay. And the next bill that we have is LD 603. Let me find the bill analysis so that I can share it.
Thank you for doing this for me today.
No problem.
I didn't know what would happen if I got out and got back in. So
Yeah, no problem.
and I don't want to make you wait. So here we go.
Okay.
LD 603, this is an act regarding the practice of pharmacy. There are 3 sections of the bill. The first 2 sections of the bill would amend the definition of the terms pharmacist and the practice of pharmacy in the Maine Pharmacy Act to add language specifying that a pharmacist is an individual provider of healthcare services, and that the practice of pharmacy means the provision of healthcare services that include the specific activities within a pharmacist's recognized scope of practice. Section 3 of the bill would add language specifying that a pharmacist may administer medication, drugs, devices, and other materials within the practice of pharmacy, and then would require the Maine Board of Pharmacy to establish specifications for administering those types of things: medications, drugs, devices, and other materials. I linked to the testimony as well. And then this came up at the public hearing, but this bill has had a fair amount of legislative history in the last 2 sessions. It was considered in the 129th legislature. That bill contained only sections 1 and 2 of LD 603. So the third provision that I just mentioned related to administration of medications was not included in prior versions of this legislation. LD 267 was a divided report, and when it was considered by the HCIFS committee and died between the bodies. The proposal was also considered in the 128th legislature and also died between the bodies. It was the minority ought to pass reports in, the House and Senate differed in their acceptance of each report that was out of the committee in each of those sessions. And I'm happy to provide more information if you have any questions about the prior legislative history of each of the bills. So one of the issues I think to consider, and it was raised at the public hearing, is what other consequences of recognizing pharmacists as healthcare providers. Is it intended to indirectly expand their scope of practice or allow billing or direct reimbursement for services provided by pharmacists? Proponents did indicate that pharmacists may be able to negotiate with payers for payment for certain services, but the bill as drafted does not mandate insurance reimbursement. Proponents also described some of the recent changes in employment settings for pharmacists that would include employment of clinical pharmacists in primary care practices. I would also note that the bill as drafted does not expand the current scope of practice for pharmacists. I guess I'm happy to talk more about the issues of reimbursement. And you've seen in other instances where once a provider is licensed and regulated, you'll often see in future legislative sessions bills that are introduced that directly relate to mandated insurance reimbursement, but that's not the case here. It's just a recognition in the Pharmacy Act of the status of pharmacists as healthcare providers. One of the things that didn't come up at the hearing this time, but it was raised in previous sessions, and I just wanted to make you aware of it is that there were concerns previously raised about whether the bill is intended to make pharmacists subject to the Maine Health Security Act, which relates to malpractice proceedings against healthcare practitioners because of how healthcare practitioner and healthcare provider is defined in the Health Security Act. Previously, it was suggested by representatives of the Maine Trial Lawyers Association that prior versions of this legislation be amended to clarify that there's no intent to affect the Health Security Act. And I included for you the language of that was added to a committee amendment when it was considered in the 128th legislature, just so you're aware of that. And as I mentioned, this bill, LD 603, contains an additional provision related to authorizing pharmacists to administer medications. And you did have testimony from proponents of the bill that it's hoped that this change will permit pharmacists to administer long-acting injectable medications for such things as birth control, mental health treatment, and other permitted purposes, consistent with their scope of practice. We don't yet have fiscal information on this, but I would note that I should have noted here, but previous versions of this legislation had no fiscal impact.
Okay, thank you, Colleen. I will open it up for discussion. Does anyone on the committee wish to make a comment? Representative Morris.
Thank you, Madam Chair. I would move up to pass.
Okay, is there a second? Representative Tepler has seconded. Is there additional discussion on the bill? Representative Melrano.
Thank you, Madam Chair. Just wanted to weigh in. I do think I'm sort of swimming against the tide here, but I can't support this bill because of the implications that it has for the pharmacist being able to bill. I think that's the last thing that Mainers need is another healthcare provider billing them. I'm concerned about the surprise that might cause. I mean, and I've heard a colleague describe it as a surprise bill. It's not technically would be a surprise bill, but I just don't want to see my constituents be surprised by being able to be billed now by their pharmacist. I think that, one of the proponents made the statement that the only reason that she wanted this was for clear recognition that they're important parts of the healthcare team, and I get that. And but this bill does more than that. It will allow pharmacists to bill, and I think that the average Mainer would not want that. I do think that they make a good salary. They do make six figures. They deserve it. They do hard work. But I can't support a bill where pharmacists will be allowed to bill going forward. And I do think, we kind of I thought we sort of were wanting to get away from the fee for service situation to help keep healthcare costs down. And this would only really expand that. Thanks.
Thanks, Representative Melrano. Representative Arford.
Yeah, I also will not be supporting this bill at this time. I agree with the reasons that Representative Milrano just expressed, and I'd like to add to that the patient safety complications that that are concerning to me. And I'd like to direct people to a testimony that was submitted since the public hearing by a gentleman named Lee Omart, who is a retired pharmacist, who is a fourth generation pharmacist in Maine. And he gives a very compelling testimony for both the pros and the cons for this legislation. And although he does support it, in further discussion with him, the issues around opening up the practice of pharmacy to delivering the long-acting injectables is something that I think requires further conversation. And also to note that in collaborative practice, currently pharmacists can do all these things. We don't need to pass this bill to allow them to function in that way.
Okay, I think we have another bill on long-acting injectables. Colleen, is that right? That's actually a separate bill.
We do have a bill that Senator Claxton has sponsored related to long-acting injectables. Yeah, I think it's scheduled for hearing next week, next Wednesday.
Right, and I think that's the scope of practice piece. This is just the rules piece. Is that right?
Yeah, I think that would be more specific, yeah, to the authority to administer the long-acting injectables, yes.
Okay, great. I don't know if that helps clarify your comment, Representative Arford, but I just want to highlight that that's actually a slightly separate issue, although obviously it's related.
And I will look forward to considering that bill. This is the first I've heard of it.
Yeah. Okay, Representative Brooks. You're on mute. There you go.
Yes, yes, this bill I'm conflicted on. I can see that our pharmacists are part of the medical team, and I do value their work as part of the medical team. And during the coronavirus crisis, their work has gone up, and they've been very helpful in making hand sanitizer, filling the role of testing place and now a vaccine place. And the thing that I am concerned about with this bill is that I believe that if a patient had a bill that they weren't expecting, I mean, I think it's important that that pharmacists get reimbursed for their work, but they don't get charged more for filling certain prescriptions that they actually lose money on because of the system the way it is now with pharmacy benefit managers or insurance companies with the pharmacy benefits managers sometimes having on their formulary a brand name drug medicine. But that's off topic, so I apologize. But there are ways that we can improve the reimbursement for medications and not have them lose money. With this bill, I am conflicted. I think that they are providers, but I do worry about patients that it could happen that they would have another out-of-pocket expense that they weren't anticipating. And I'm thinking more with services they provide now to help make sure they don't have harmful interactions. So I would just be hopeful that there could be an amendment, but I don't foresee that.
Thanks, Representative Brooks. I will, Representative Quint, go ahead.
Thank you. I just had a question, and I don't know if Representative Milrano can answer this. When we were doing the hearing, I did not hear a lot of talk about reimbursement. This was about recognition. So is there anybody that can speak to that? Because I thought that was specific as not being part of it. So I'm just a little confused now. If someone can help me, thank you.
Sure, Representative Quinn, I think that's a fair question. We do have a number of folks who are here who could speak to that, Ms. Arnold, Ms. Downing, Mr. Picard, who helped to put the bill together. It's not a very lengthy bill. It only has about 12 words in it, and none of them are about reimbursement. But it does have implications for reimbursement, most specifically in the Medicare realm, because Medicare won't reimburse pharmacists for pharmacy services unless the state has provider status for those pharmacists, which really just has the impact of reducing the sites where those Medicare patients can receive care, because they can't go to their pharmacies in Maine to receive that type of care because Medicare won't pay for it. So I guess I sort of answered that piece. It does have that implication for Medicare right away. And perhaps if Ms. Arnold or Ms. Downing want to add anything to that, you could raise your hand. Let's have Ms. Arnold come in and respond to Ms. Quinn's or Representative Quinn's question. Good afternoon, Ms. Arnold. Thanks for joining us. I hope that I said that correctly about Medicare.
You did, and pharmacy reimbursement is just an incredibly complicated issue, and I really can speak more to what your typical like brick and mortar like retail pharmacy could do, and I think there are colleagues who could better address some of those billing in more of a primary care setting. But yes, right now with no recognition in statute, it doesn't even allow the opportunity for some of the carriers to submit for services, and this is not about billing someone to come in and pick up their prescription. Prescription contracts at a retail pharmacy are negotiated based on the prescriptions that we're filling there, and that does not change that. You can look to any of the other 40 states that have passed this to see there are no skeletons in the closet there on that one. But pharmacy is a really diverse profession, and I think that it's important to recognize, rather than focusing just on that one scenario of someone going to a pharmacy counter and getting billed for something they're not expecting, the opportunities that this presents by being recognized as providers in all of those different areas. So if there's more specific questions, I can talk myself in circles all afternoon on this one, but I'll let you all maybe direct me to specific questions there.
Representative Quinn, I'm going to go back to you first and ask if you had a more specific question that you wanted Ms. Arnold to address.
No, thank you. Just overall, I was wondering because, like I said, it was a little unclear in the hearing, and then to have something brought up now, I just need to concrete it in my mind. Thank you.
Sure. Representative Morris, let's have you chime in next. Representative Arford, we'll come back to you since you've spoken already.
Yes, thank you, Madam Chair. And I also want to thank Ms. Arnold. I've called her with some questions that we've had over the last week. She's been very helpful. And I just think hopefully she can just share with the whole group kind of what she shared with me over this issue. As I understand it, this is really about streamlining that process, because right now you kind of have to go back to another provider to get the prescription, if I remember correctly from our conversations.
Yeah, I mean, we are so much a prescription, that's what pharmacists who came about were for prescriptions, but there are pharmacists now embedded in primary care offices in particular that this really affects, because if someone wants to make an appointment to go over their medications right now, they're not, we're not recognized as someone in statute that has the ability really to provide those services and bill Medicare for it. We have this extensive education and it doesn't allow it. If someone's going to come and sit down with me right now, my only choice would be to say, if you want to sit down with me in this primary care setting, and Dr. Matt Marston can speak a little better to this too, I have to have another provider involved in every step of that process. It's about, I shared with all of you committee members, something that really touched me last week, and it was vaccinating the Maine New Mainer project here, Capital Area New Mainer project in Augusta, and just how wonderful it is to be able to be a piece of vaccinating new Mainers in Augusta, and how I'm able to do that now because of LD1. But before that, when we started these vaccines in December, because of an emergency order by the governor. And so rather than having to be any case that, we have to go back and pass a law, or, we have to create a working bill around in Maine Care, or, we have to get an emergency order issue, let's just get it out there and remove that barrier to care in a very rural state that has shown us the inequity across the state with healthcare. And pharmacies, you know, President Biden recognizes it, that pharmacies, 90% of Americans live within 5 miles of a pharmacy. So think about the opportunity that could hold in the future, and don't be held back by fear of something that's not happening in 40 other states already that have passed this legislation.
Representative Arford, go ahead.
Thank you very much, Madam Chair, and thank you, Ms. Arnold, for speaking with us. I just want to first say, although I am a first-term representative, it's become very clear to me that we are constantly, year by year, updating and evolving our laws to meet needs as we go forward. So I want to make sure I understand exactly what this bill does, because if I'm misunderstanding it, I may well change my vote. Because my understanding is that this bill, by changing the designation of a pharmacist to include healthcare provider or medical provider, with the specific terminology, it will then allow the pharmacy to bill for the services that they provide under that designation, which includes the delivery of long-acting injectables, as well as services like consultation on medications, which now is a service that's provided without any charge. It's something that is very much appreciated by the people of Maine. I know I very much appreciate it. And I've always assumed it comes under the cost of my medication, which is usually very significant. And I've been led to believe so far by the testimony and the conversations I've had that if we were to pass this legislation, those services would now be billable services that would, of course, they would have to be negotiated with the private and the public payers, but potentially they could become billable services, as would, if we pass telehealth bills going forward in this session, telehealth services that pharmacists could deliver could be billable services. And I would appreciate it if a person who knows the answer to this question could answer it, because if I'm under the wrong impression here, I definitely would like to be corrected.
So I think I can answer your question. And again, pharmacy is very diverse. My practice setting is I'm the operations manager for a small chain of pharmacies in Maine. So I am very ingrained in what Maine laws are. I am very aware of what insurance contracts are, and can tell you that when we sign a contract with an insurance carrier or a PBM, we sign a contract saying we're going to dispense that medication and we're not going to bill any balance billing to the patients. You accept payment for what the medication is. So to me, that's very clear. You can't say, oh, I'm only going to tell you about this Lipitor if you pay me to tell you about this Lipitor, because we already have signed contracts across these plans to say that. In addition, Maine law mandates that pharmacists counsel new prescriptions. So it's not going to change that. You're still going to be able to get your counseling. It's mandated in federal law with the OBRA 90 Act, and it's mandated in Maine law that pharmacists counsel on prescriptions. So this isn't about that pharmacist to patient interaction. This is about other interactions that can occur not in the delivery of that medication, but all of the other services that we can so greatly provide. So Medicare Part D recognizes, for instance, that pharmacists are a valuable team member and will pay pharmacists to do a comprehensive med review once a year for patients' medications if they qualify in a Medicare Part D plan. We can do that because it's written into Medicare Part D law. A commercial insurance plan, those commercial patients could very well benefit from that as well, but that's not written into law, and nowhere does it say that a pharmacist is able to bill for those services. We're not a provider of those services. So the federal government in some ways recognizes it in just very piecemeal fashions. And we can either, in my take on it, continue to pick them off one by one of the specific scenarios. Oh, there's this scenario such as pharmacists prescribing PrEP medications. You know, that could be a scenario that I think pharmacists would step up to and would say, yep, we want to take the appropriate training and we want to make sure that patients who need this medication and this access to care have it. But if you pass a law saying pharmacists can prescribe PrEP medications, I can already envision what at least Maine Care Services is going to say is they're going to say pharmacists aren't providers. Sorry, we have to figure out how we're going to be able to allow them to bill for those medications, because it happened already with naloxone. So how many times are we going to piecemeal these one scenarios here to say, oh yeah, well, we want them to value this. You know, we're just going to pick them off one at a time. Maine was the 50th state in the nation to give pharmacists the authority to immunize, number 50. So we can either be number 41 with provider status, or we can keep letting our fear of the unknown here that's not happening in other states hold us back and let us be number 50 again.
So
Representative Arford, go ahead.
yeah, that you covered a lot of territory there. Thank you very much. But
Thank you for the question. And I appreciate your passion and I share your passion.
Well,
so thank you.
I'm still not clear that my original question was answered. What I specifically wanted to know was, part of what I wanted to know was, in terms of these medication consultations that you are now required by law to provide and are not billed separately. There's no billing for that service whatsoever. There never has been. But once this bill passes, you would then be able to bill for that particular service as a separate charge than the medication. So I go in, I have a diabetic.
I'm not sure where that notion would come about, because we are contracted to dispense the medication and we're paid to dispense the medication, and what we're paid to dispense includes the dispensing fee, which includes that counseling piece of it. So you can look at all other 40 states and that's not happening in any of those states. I can say that with confidence.
Thank you very much.
Thank you.
Okay. Representative Brooks.
Yes, as I said, I'm conflicted still on the bill, but I'm hopeful that there won't be any ill effects on patients going forward. And I do think this crisis at this time, pharmacists have stepped up. I'm gonna support the bill.
Thank you, Representative Brooks.
Thanks, Representative Brooks. Are there additional questions for Ms. Arnold? All right, I'm going to thank you for joining our work session, and we'll move you back into the attendee group. Thank you. Okay. Are there additional comments from the committee at this time? Representative Arford, go ahead.
I am going to support this bill. And in supporting it, because I will be here for at least one more term, we discussed earlier the possibility of some sort of going forward evaluation of the financial consequences of this. And I'm not asking that we amend the bill to conclude that. I'm just saying that I know there's ways to assess that, and I will be looking at ways to do that as we go forward. But not just because of what I've just heard, but because I also know that the addiction and substance use community supports this bill, because they believe it will make very much needed injectables and other services available to their population, especially in the rural parts of the state. I am now convinced that this is the right thing to do, and I will be supporting it.
Okay, thank you. Are there additional comments on the bill? Okay, there is a motion that ought to pass. Is it ought to pass as amended, or is it ought to pass? It's just ought to pass.
Ought to pass, yes.
Yeah, okay. So there's a motion and a second, and I don't see any other hands raised. So I'll ask the clerk to call the roll.
Representative Quint.
Yes.
Representative Quint, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Blyer.
Yes.
Representative Blyer, yes. Representative Morris.
Yes.
Representative Morris, yes. Representative Matheson.
Yes.
Representative Matheson, yes. Representative Evans is absent. Representative Arford.
Yes.
Representative Arford, yes. Representative Melorano.
No.
Representative Melorano, no. Representative Brooks.
Yes.
Representative Brooks, yes. Senator Stewart.
Yes.
Senator Stewart, yes. Senator Brenner.
Yes.
Senator Brenner, yes. Representative Tepler.
Yes.
Representative Tepler, yes. Senator Sanborn.
Yes.
Senator Sanborn, yes. That's 11 yes, 1 no, 1 absent.
Okay.
Melorano, can I just just ask real quickly what your report is? Would it be ought
not to pass?
Okay.
Thank you.
Great. So I think with that, we've concluded our work sessions for the afternoon. Colleen, do you have anything else for us this afternoon?
I don't have anything else, but I would like to touch base with about scheduling work sessions, if we could, either offline or on this call after folks drop off.
Sure. I have another meeting that started at 2, so let me get back to you on that later on this afternoon.
That'd be great. Thank you.
Okay, great. Excellent. Anything else from anyone else? All right, thanks for joining.
I'm not,
Go ahead, Representative Tepler. I asked anything else and you didn't say anything. Go ahead.
well, I was trying to, and I thought I was muted, but I wasn't. I just want to say that I'm not available around from 4 to 5 p.m. So as you parse out availability, let's just be aware of that. Thank you.
Anything else? All right. Thanks, everybody.